برنامج. دكتور فريد، السلام عليكم.
هي فوزي ازيك؟
الصوت حلو يا
سامعني؟
دكتور فريد كده؟
وصوتك برضه ضعيف يا دكتور محمد.
يبقى انا طيب اساين ان من اللابتوب برضه، مش عارف
هو
الديسك
يعني
كده.
عايز تعليه شويه بس مش عارف. انت سامعني كويس؟
انا سامعك كويس جدا. عبد العزيز شغل الفيديوز للبانل.
الفيديو بتاعنا دكتور صلاح الدين معانا كمان.
اه
ايوه،
صلاح،
السلام
ازيك؟
عليكم، مرحبا.
اهلا
عليكم
بيك يا دكتور
السلام.
صلاح، منورنا.
ايه الاخبار؟ كيف الصحه؟
كان نفسنا نشوفك والله، بس للاسف بقى اللي احنا فيه ده.
والله نحن لسه عندنا الدسكشن على السعودي سباين ميتنج، يمكن يكون ان بيرسون او شيء. والله نشوف.
عبد العزيز استنى شويه. عبد العزيز بتقول ايه يا دكتور صلاح؟
بقول نحن لسه عندنا دسكشن في السعودي سباين انوال ميتنج، انه يمكن يكون ان بيرسون، فان شاء الله تكونوا كلكم موجودين معنا باذن الله.
يا رب يا رب.
نفتتح هذا، نفتتح ما بعد كورونا يعني. يلا الله يسهل. لا، قربت ان شاء الله باذن الله.
ان شاء الله ان شاء الله. طبعا عبد العزيز شغال ولا ممكن؟
دكتور شريف سامعني كده كويس؟ دكتور شريف
محمد سامع كويس.
طب تمام دكتور يسري رون is here عبد العزيز can you stop عبد العزيز can you stop the promo and allow the camera for the panelist please. السلام عليكم دكتور يسري.
عليكم السلام.
احنا
ازيك يا
رون
محمد؟
الحمد لله. رون معانا ودكتور شريف وسامر سامي وصلاح الخليفه ودكتور محمد مشتاوي. هاي رون, how are you?
Fine, thank you. How are you?
I'm
Hi,
fine.
Ron. Great to see you.
Hello, Dr. Alawari.
Fine, thank you. So, how is the weather your side?
It's good. It's pleasant, you know, about 20, 25 Celsius every day. We're at our family's home on the ocean. It's been very good here.
Excellent, very good.
Yes.
Send us some colder weather because we are frying here.
It must be too hot right now, for sure.
Yes, it is. Great. It will be a great session. Thank you for to have you. And let's hope that next year you will be able to join in physically, inshallah.
Oh, I'd love to. Thank you.
Great. So, Mohammed Khattab,
ايوه دكتور يسري. أيوة.
we're going to start at 6 sharp.
At 6 sharp ان شاء الله we'll start.
Okay.
I will send the panelist link to Dr. Amir Aziz because he has a problem. So just a minute and I will sign in again, okay?
All right. Is Ron there? Ron, are you still there?
I'm here, yes.
We had in the past 2 days, we had very nice presentation and discussions from several international and national speakers. And we were going through the approaches and then several techniques. And now today would be on challenges in fixation. And you will start with the most challenging and innovative part, which is fusionless correction. So okay. We reached like 150 attendance in the last 2 days. And I think today we're starting now by 33, but they will add on during the coming 2 hours.
Okay. Will there be time for questions right after the talk, or is it later on?
No, later on. Are you with us
Okay.
till the end of the session?
I don't think I'm able to stay till the very end of the session, unfortunately.
I'll tell you what we can tell us when you're leaving, and then we can stop and do some questions.
Okay. Let me look at the program here.
Because your talk might be related to the others.
Yes.
So you
It
tell
doesn't-
me when would you like to stop and
Sure. It doesn't
Question.
look like there's much relationship to these talks. It looks like there's relationship to some talks from yesterday, but not to the session generally.
all right. So Ron, we can have some questions after your talk, since it's not related, and then you would be able to leave whenever you want.
Okay,
Shall we
thank
do
you. Apologies for that. Yes, sounds
Okay.
good.
Very good. Sorry, we're missing Yahya because he's operating.
Oh, is he? That's too bad.
Uh,
Are you still doing a lot of surgeries this week like you usually do for Scoliosis Week?
yes.
Yeah.
We usually do like 2 per day, and we operate 3 days a week.
Okay.
We had a very interesting talk yesterday from Dr. Walid Haker from UK Leeds, and they found out that because of the COVID, they had delayed the presentation of the scoliosis, and they started to see 100 degrees scoliosis. What we normally see here, but in UK, because there was no waiting list for scoliosis, so they will only see the 40 and 50 degrees. But because they didn't operate, then they all had severe curves. Do you experience such a thing in Canada during COVID?
We experience more. We have a long waiting list, 1 to 2 years for older patients for sure. So we might book them at 50 or 60 degrees, and are usually 70 or 80 degrees would be typical for us. With COVID, we had to stop ORs for a few months. So it wasn't that they presented bigger, they just got that much bigger while they're on a waiting list.
Okay. And there is no short track for patients with progressive curves or higher prognostic that they will progress?
Yeah, it's at our discretion as a surgeon. So we triage our own list. So if there's somebody who has a big curve or high risk of progression, then they bump up on the list, and we might do them in 3 to 6 months. Whereas a 17-year-old 55-degree curve, that goes lower on the list, and that might wait 2 years. So it's up to us to manage our own list.
And you don't have an alternative route like private in Canada, do you have? So it's
not at all.
One track.
Yeah, for sure. It's even difficult going to another city in Canada. You have to pretty much stay in your own province. It's very difficult to go to another province or another city.
Okay. And are you planning the government to do like a waiting list initiative for example, scoliosis, because they get worse and by time?
Yeah, this is despite an initiative since 2013 where we've almost doubled our scoliosis volumes in terms of extra money coming to the hospital. The anesthesiologists get paid extra to do these cases. So that's even with that initiative, we still have a long waiting list here in Nova Scotia.
And approximately how many cases do you have on the waiting list?
I do about 70 per year. And so at any one time, there's 50 to 60 on the list. You know, I might do one case per week, sometimes 2 cases per week, plus all the cast changes and lengthenings, things like that.
So I think you need Yahya to get back and do some cases.
Oh yeah, we were very efficient when Yahya was here, that's for sure.
Actually, he's very good, yeah. And he's doing more and more difficult cases, and he's really very impressive. He's one of our team, but he also works in Zagazik and operates there. But he's a very good asset.
Yeah, he was a phenomenal fellow. We enjoyed having him with us. He was with us for 2 years doing a lot of research as well. And I think it really makes a difference to be somewhere for 2 years rather than 1 year, you can really accomplish that much more.
Yes, I would agree. At least a year to learn the spine surgery and another year to perfect it.
Yeah, exactly. And that's what we saw Yahya do.
Very good.
Hi, everyone. Hope you're
Hello,
all very
Amir.
well.
Excellent.
Hi, Ron. I'm Amir from
Hi.
Pakistan. Hi,
Nice seeing
Yusri.
you.
How
Hi,
are
Amir.
you?
Excellent. Great to see you. Very
Great to
good.
see you all. Brilliant.
You look great, Amir. Huh?
I am well.
And congratulations for the chairperson of the Middle East.
I
It was
hope,
fun.
Yusri, we can do something. The way AO is headed, I hope it doesn't slip out. There's a lot of problems with the board and the surgeons, so I hope this can be sorted out.
I tell you, the COVID had changed a lot in societies because you no longer meet in person. So we lost this no meetings. They were on the web. So I think we lost a lot, and other societies are really in trouble.
Yeah. So Ron, did you do a lot of surgery during the COVID period in Canada?
We, in 2020, from the middle of March to the end of May, we didn't do any. And then we gradually came back to full strength for the past year. So it affected us maybe for 2 or 3 months. We were very, very slow, but we're still trying to catch up from that. I was saying earlier, our waiting lists are, close to 2 years for some patients. So to add another 3 months made a big difference.
There's a very interesting paper from Edinburgh in which they interviewed the patients, especially the joint replacement ones, whose waiting time was extended because of this. And they use the term that this wait is worse than
Sorry,
death.
I can't hear you. I think the internet froze here.
Can you hear me now?
Okay.
Yes.
I can hear you now, yes.
Yeah. They did a survey of patients waiting for their joint replacements in Edinburgh, and their waiting time was extended because of the COVID thing. And these patients said that this extended wait is worse than death scenario. So then the National Health had a rethought, and they thought they had overshot the precautions. And that's when the work started picking up. But we were lucky
Right.
here. We didn't stop at all. It was almost the same
Good.
workload here. So we were very fortunate on that.
We've been very cautious here, and our case counts in Nova Scotia have been quite low, but we've been very cautious with allowing people to come in and out of our province. And it's paid off because low case counts, but it's had an effect on the medical system for sure.
Right.
Assalamu alaikum, Dr. Amir. How are you, sir?
Assalamu wa rahmatullah.
I'd like to thank the whole panelists and faculty for attending our 5th International Egyptian Scoliosis Society meeting. And Professor Yusri, can you start our third day, sir, please?
Thank you, everybody. It's a pleasure to have you for the third day. And today's sessions will be on the challenges in fixation of scoliosis or spinal deformities. And I'm very glad to start with our first speaker, Dr. Ron El-Hawari. Dr. Ron El-Hawari is my shadow brother in Canada. He's the head of the orthopedic department at the Dalhousie University, and he's the president of the pediatric orthopedic society, and he's one of the fastest growing spinal surgeons in North America. So I'm very glad to have you, and can you please start your first presentation on fusionless techniques in AIS?
Yes, for sure. Thank you very much for the lovely introduction. I first met you at my first SRS in Monterey, California years ago when they double booked the hotel room under the name Al Hawari. So I had to stay at a cheap motel while Professor Al Hawari got the nice hotel room. But when I met you then, you turned out to be a really, really super guy. And it's been a pleasure being your shadow pediatric orthopedic spine surgeon through the SRS and internationally. So we'll talk over the next 15 minutes or so about fusionless surgery for AIS. I do have some disclosures, including diffuse synthes, Medtronic, and orthopediatrics. It's a pleasure being here as part of the Egyptian Scoliosis Society. We've trained a couple of fellows from Egypt, Yahya El Bramboli and Walid Kishta, and we're hoping to continue on our close relationship with your group. And I see that the Saudi and the Jordanians are part of this as well. And we've had several fellows from both of those countries. So thank you for having me. I do have Egyptian heritage. My mother and father are both from Egypt. And here's a picture of my late parents, Dr. Mohammed Al Hawari, who was an electrical engineering prof, and my mother and I on the shores of Alexandria when we were both quite a bit younger. So I'd like to dedicate this talk to my late parents. So the overview, we'll briefly talk about what we call the need for scoliosis surgery that's fusionless. We'll talk about the Canadian experience on VBT, some papers that we've been a part of looking at complications in VBT and the effects of BMI on VBT outcomes. We'll then transition to the ApiFix, or the posterior dynamic deformity correction device. We'll review some biomechanical tests and some studies that have led us now to our current philosophies of treatment. And then a quick sneak peek at a study that we've done comparing three-dimensional spinal pelvic comparison for VBT versus the ApiFix. So we're all familiar with Harrington rods. They've been around for a long time, and were the standard of care. But back in the 1960s to 70s, when they were introduced, it was seen to be very novel and very innovative. Although looking back from our perspective, we can see that they're now seen as old-fashioned. But at one point, they were very revolutionary. And I borrowed these slides from Baron Launer, which kind of illustrate the point of the innovation that we're trying to convey. And looking at fusionless surgeries, it is very innovative. SRS surgeons that put together this newsletter submission, looking at kind of the past, present, and future of scoliosis. And in it, we'd had a chance to look at the the history of spinal fixation and Harrington's rods themselves. When he presented these at the American Academy of Orthopedic Surgeons in 1958, people thought he was crazy. They thought it was an abomination to be doing spine fusion surgery with instrumentation. But then it became the gold standard. So the road is not easy. And this has been highlighted in this book called Dogged Persistence about Harrington's life and the challenges he faced to bring the Harrington rod into existence, and as a revolutionary form of treatment that eventually turned into the gold standard. And that paved the way towards many other innovations. So that brings us to what's commonplace now in 2021, and that's pedicle screws, including the thoracic spine. You get great three-dimensional correction, and we're very pleased to show these X-rays. You get great results radiographically, but at the end of the day, it's still a fusion operation, and just the same as we don't fuse knees and hips for arthritis anymore, we do arthroplasties. I don't think fusion is the ultimate answer for scoliosis correction. We recognize that there is increased risk of degenerative disc disease in the unfused segments, and that the rods in the instrumented segments can cause limitation in movement. So not ideal, but it is currently the gold standard. So we'll look at bracing as well, which is the gold standard for kids with moderate scoliosis with progressive curves. Looking at the results of the BRACED study, 72% were successful, but that there's 28% that progressed to greater than 50 degrees and will be fused. So we're trying to identify patients who may progress and try to treat them surgically earlier rather than allowing them to get really big and treating them with a fusion. So we were part of this study looking for risk factors for failure in bracing, a literature review, and I'll kind of zoom in on the top 3 risk factors in which brace may not work and the patient may progress to fusion surgery. And that's related to poor brace compliance, lack of skeletal maturity, and larger Cobb angle. So we're trying to identify these patients, that 28% of patients who brace may not work for them. And rather than jumping to a fusion operation or waiting till the curve's 50 or 60 degrees to fuse, maybe doing a lesser operation like VBT or ApiFix at that time. Secondly, when we look at the literature on the natural history of scoliosis and progression at maturity, this is a landmark study, still the best study to date, looking at this by Weinstein and Ponseti in Iowa, where you can see that all of the dots above that oblique line, those are patients who progressed beyond maturity, and they concluded that a curve over 50 degrees will progress at maturity. But in between those 2 red lines, there's no data points. That's between 40 and 50 degrees. So we don't know for sure that 50 degrees is that threshold. So I think there is a trend in North America anyway to be operating on slightly smaller curves, and fusion seems to be a big hit for some of these smaller curves. Again, opens the door to some fusionless treatments. For both of these fusionless options, they are very innovative. And when you look at this bell curve of surgical innovation, we're on the far left here, that where the enthusiasts and the early adopters, not many people should be doing these surgeries just yet until we have more data and more refinement of the indications as well as the surgical techniques. So we're right at that chasm. We're trying to bridge that chasm and get enough evidence and perfect the technique enough that other people can do it and get good success. And I've certainly had my share of successes as well as my share of failures along this learning curve. And I hope you can all learn from these. So it's those cases between bracing and fusion. That's where we're looking at those moderate curves where you can do something like the posterior dynamic deformity correction or VBT. So the FDA in the US just approved the VBT in 2019. A lot of people have had some experience prior to that using it off label. And I think you're all familiar with the concept of it. I think Dr. Trobesh had given a couple of talks yesterday on this, but it's basically a convex hemiepiphysiodesis in a growing child. And it's generally for Lenke 1, Lenke 5, and Lenke 6 curves. Here's a quick case of a 12-year-old girl, idiopathic scoliosis, Lenke 1 curve pattern and hypokyphotic. And here she is after the VBT was in place, and you can kind of see that growth modulating effect from preoperative to first erect to a year and a bit post-operatively. So it's designed to get correction on the table as well as further correction over time as the patient grows. In Canada, we firmly believe that it is for growth modulation, and we reserve the VBTs for patients who are still growing. There are several surgeons elsewhere who are using it in mature patients, but we're still looking to see some more data before we adopt that in Canada. So we have a bit of a VBT research consortium in Canada. In the middle of the image, you can see Stefan Perrant, Feroz Mianji, Neil Saran, Kevin Smith. Kind of the 5 of us have been doing a lot of research together on VBT and utilizing the Spinalogics vertebral body tether, the study that we've been involved in. These are the indications, but of note, it's curves between 40 and 70, skeletally immature. And here are some of our early results from the pediatric spine study group looking at the risk of early complications following VBT. Our hypothesis was there's low rates of early complications and unplanned return to the operating room. Retrospective review of prospectively collected data, similar inclusion criteria to what I showed on the previous slide. And of all the patients in the PSSG study group, you can see how we got down to our 120 patients. At this point in time, the Americans were not entering patients in the PSSG yet because it was off-label. So it was just Canadian centers. So these are results from Montreal, Vancouver, and Halifax, Canada. And you can see the improvement from pre-op to immediate post-op, 51 to 27 degrees. But then by 1 year and 2 year post-op, not much more correction after that. And really no effect on the kyphosis. We do these all thoracoscopically through 4 or 5 portals. The mean anesthesia time, 304 minutes, mean surgical time, 215 minutes, and mean hospital stay, about 4.5 days. And from that large multi-center series, there was a 16% complication rate and 17% uproar rate at 2 years post-operatively. What we saw was that these rates increased over time. So you compare immediately post-op to 3 months post-op to 1 year to 2 years, these rates continued to climb. And what we found is the first year, the complications were mainly pulmonary. Second year, we started getting mechanical type complications such as cable failure or overcorrection. And I think we'll continue to study this cohort over 4 and 5 years. And I think we'll see more complications over time. So certainly some room for improvement, but this was based on cases that would have been done 2014 to 2017. We also started looking at risk factors for what might increase the risk of these surgeries not to work. And we thought BMI may be one of those risk factors. So we presented this at POSNA this year, and we just submitted it for publication this summer. And I'll kind of jump to the money slide here. And that's the percent scoliosis correction over time between underweight patients, normal weight patients, and overweight patients. There really wasn't any difference in the correction on the table, so pre-op to first erect. However, when you look at that growth modulation phase from immediate post-op to 2 years post-op, you had further correction of the scoliosis in underweight patients. Normal weight patients didn't really change, but the overweight patients, the obese patients, they actually had a worsening of their scoliosis over time. So there's a risk ratio for scoliosis progression in the growth modulation phase for overweight patients of 4.7. So we're thinking about that now with our patient selection and avoiding to use this technique in overweight patients. There's no difference in complication rate based on the different weight categories. We'll jump to the posterior dynamic deformity correction device, the ApiFix. Kind of looks like a Harrington rod when you look at it on an X-ray, but what's unique and what protects it from early breakage and failure are these little joints that are polyaxial. They allow lots of movement, 50 degrees freedom between the screws and the rod. So that should dampen the force as the patient moves, so the rod isn't as likely to break. It's placed on the concave side, it's posterior, which makes it easier to implant than the anterior VBT. We were involved with some biomechanical testing and it compared quite favorably to other devices. And the group in the Netherlands had looked at cadaveric and animal models to demonstrate that range of motion is better with the ApiFix device as compared to a fusion type device. So fusion, you lose about 80% to 100% in flexion extension, bending, and rotation. With the ApiFix, there is only 40% reduction in flexion extension, 18% reduction in bending, no difference in axial plane rotation. So a proof of concept of allowing more range of motion. Now that same group in the Netherlands, some good friends of mine, Moyo and Marinus, we've done some other work together. Their experience, they're the group that actually looked at the animal and cadaveric testing, but when they looked at their clinical data, they had 10 patients requiring revision surgery. This was with an early version of the device, but you can get a snapshot of the surgical time, blood loss, length of incision, length of hospital stay, much less invasive than a fusion type operation. And you can see there are differences here in the sagittal plane and their SRS patient reported outcomes. improved considerably from 2.6 total pre-op to 4.3 at latest follow-up. So patients were happy. However, there was a high revision rate. The device has changed quite a bit since these early cases, and the indications have improved. I'm going to jump through a little bit of this for the sake of time, because I think what's most important here are the kind of current way of how we implant this and what the current indications are. We found that by bridging more segments, we get better correction. And the study from the Netherlands was shorter segments and without the extender. So now we use one screw at the base and then two screws with this extender. So 3-screw system, and going across between 5 and 7 segments, we get better correction. And here's a patient of mine where we see that correction early on. And we feel that if you can improve the scoliosis to less than 15 degrees, and it's more than 3 years post-operatively, you can take the device out and not have the scoliosis return. That's still being studied, but that's our hope over time. So the indications and the device have evolved over time. You can see the early device, short segment, moderate segment in the middle, and then the current on the far right. So we can look at these immature patients, the failed bracing patients, where it's kind of 35 to 45 degrees. I think this is probably where the money is in terms of the patient population that's best served for this. That might be that 28% that fail bracing. So rather than doing a fusion for such a small curve, you can do a 1.5-hour operation to place the ApiFix, keep it in for a few years, then decide if you take it out or leave it. We've demonstrated that you can get a bit of growth modulation utilizing this device. And you look at the apical vertebral wedging at last follow-up in the RISR 0 and 1 patients, you actually had an improvement of 4 degrees apical wedging at last follow-up. So we think that by unloading the spine in these young kids, that the vertebral wedging can improve, and hopefully you can safely take the implant out over time. The other alternative is to fusion. So these are the more mature patients, the bigger curves, and it's more of a late intervention. And here's a case of example of mine. The third indication that's still being studied in Europe right now is that for early onset scoliosis is through that ratcheting distraction mechanism. This can probably self-lengthen in these young kids, but early results right now. These are the current indications in the United States. And what's most important for all of these, if I go back, is lateral bending to less than or equal to 30 degrees. And I've seen that change over time from 40 degrees to 35 to 30, but truly the more flexible the curve is, the better your outcomes are going to be. So 35 to 60 degrees, Lenke 1 and Lenke 5, bending to less than 30 degrees. Those are the indications in the US. The PEDS spine study group is housing the registry data, and there's 200 patients that are currently being enrolled in the US right now as part of this FDA study. You can see the centers listed here, kind of coast to coast in the United States. As of June, 60 cases have been completed in the US, still several more to go. And here's, again, a snapshot of their results in the US. They're operating on smaller curves than I have, typically 46 degrees, improving down to 21 degrees immediately post-op, and length of the procedure about an hour and a half, 25 cc's of blood loss. And similar for the Lenke 5 patients. (49 degrees to 20 degrees), slightly longer procedure. And just another quick case, 3-dimension, very flexible curves. Here's the patient immediately post-op and 2 years post-operatively. I've been getting bending and stretch x-rays with the device in place around a 2-year post-op mark to demonstrate that the spine has not fused. And you can see with the change in the scoliosis magnitude, as well as the angle between the extenders and the device, that the spine has not fused. I'll finish off with a study that we've just submitted for ICIOS, International Congress Early Onset Scoliosis, and that's comparing the two techniques, looking at 3-dimensional radiographs and spinal pelvic parameters. Because one of the questions is, well, if there's two fusionless techniques, when would you use one versus the other? So it was a single center study at the IWK, retrospectively reviewing or prospectively collected data, and looked at EOS images, three-dimensional biplanar images. We measured all of the typical coronal and sagittal plane measures, as well as apical vertebral rotation and apical vertebral translation. And I won't give you all of the results until we at least present it at a peer-reviewed conference. But just in general, we had 15 APIFIX, 13 VBT that we had compared, mean age 14 years. Scoliosis for the group improved from 54 to 30 degrees. And both techniques improved the major and minor scoliosis, as well as the vertebral rotation, vertebral translation. There were changes in the sagittal plane with a decrease in sacral slope and an increase in pelvic tilt. So some reciprocal changes. We're still studying to figure out the exact significance of that. And the APIFIX did show an increase in thoracic kyphosis, and the VBT showed a better improvement in apical vertebral rotation. So potentially, if somebody has more apical rotation, VBT may be the better option, or if somebody's hypokyphotic, the APIFIX may be the better option. Again, we need more study of this and a better look at this data. So in conclusion, I think there's a need for innovation in our field. Fusion's not the ultimate answer. Both VBT and APIFIX show promising early results, but more research in innovation is required. So thank you very much.
Ron, thank you very much. Great talk. And I think we'll have a couple of questions because you're leaving. So can I ask about posterior tethering in the lumbar and thoracolumbar spine? Do you think it can work?
So utilizing a tether like you do anteriorly, but placing it in the posterior. Yeah, I think there's been some early clinical work looking at that. And to date, it had not worked out very well. I wouldn't give up hope. I think that may be the option down the road. I think that's the posterior devices probably work better with a more solid rod that has the polyaxial joints, such as the PDDC or APIFIX. I think that's probably a better material posteriorly than the type of tether that's used anteriorly.
And is there a place for a hybrid construct in which you fuse the apex and then fusionless for the upper and lower part?
Yeah, I think that might be the next step in the development of this, is to be combining some of these techniques with very limited fusions in part of it and a fusionless surgery elsewhere. I think we want to be avoiding the long fusions. So if you can do a hybrid, that may be the way to go. I haven't done any myself, and I haven't seen any published literature on that, but I think that will be coming down the pipe soon.
Great, Ron. Thank you very much for being with us. And if you want to leave or you stay till the end, we would love to have you. Okay. Thank you very much, Ron.
Thank you. Bye.
And goodbye. A great pleasure to present our next speaker from Saudi Arabia, one of our pillars in Saudi Arabia, and Dr. Walid Awad. Dr. Walid is an associate professor of orthopedic and spine surgery in King Saud University. And Dr. Walid will present on management of angular deformities. Dr. Walid, can you start your presentation, please?
Thank you very much, Professor, for the invitation. I would like again to thank the Egyptian Scoliosis Society for the invitation. We'll talk about the management of fixed angular deformity of the spine. We know that it could be kyphoscoliosis or fixed kyphosis. The kyphosis could be acute angular or round kyphosis. The general surgical goals: correcting of the deformity, achieving the spinal balance, relieving the pain, prevent worsening and recurrence, prevent and alleviate paraplegia and severe acute angular kyphosis, as well as improving the respiratory and digestive function. Multiple osteotomies needed or single osteotomy technique for the correction. Most commonly used are Smith-Peterson osteotomy, bone osteotomy, pedicle subtraction, disc bone osteotomy, vertebral column resection, whether anterior versus posterior vertebral column, and other like closing, opening wedge, and vertebral column decancellation. This is well known for every one of you, but generally speaking, initially the Smith-Peterson osteotomy described in 1945 for diffused deformity as ankylosing spondylitis or fused spine, while bone osteotomy in 1984 for the mobile segment as in Sherman kyphosis. But currently the term used interchangeably. The Smith-Peterson osteotomy, as we know it, it's removing the inferior facet of the level above and the superior facet level below with ligamentum flavum. The amount of the correction achieved will be based on the height removed. So you can achieve 1 millimeter correction per 1 degree correction per 1 millimeter. And if you removed 1 centimeter, you can reach up to 10 degree of correction. It's suitable for minor deformities and flexible disc. Generally speaking, you should keep in mind that you can get around 4.2% of neuromonitoring changes increase compared to the standard. So the standard is around 4.2, but you can actually get up to 10% neuromonitoring changes with doing the bone osteotomy. The next powerful tool is the pedicle subtraction osteotomy, as shown in this diagram, as known for every one of you. So it is used for sagittal level, single level osteotomy can produce up to 40% correction, and global balance achieve correction up to 9 centimeter to 19 centimeter from the plumb line. You can expect neuromonitoring changes 20% with intraoperatively and 11% postoperative. Neurological deficit with permanent will be around 2.8%. If we're talking about bone disc bone, it's similar to the bone osteotomy, but with robust removal of the vertebral body, inferior and superior, with adjacent disc level. And you could achieve correction according to the amount of bone removed from 35 to 60%. Again, the main indication here that the deformity at the apex of the disc space. The next will be vertebral column resection, where it's full vertebral body with disc above and below, including the inferior segment, superior articular burst level below, inferior articular burst level below, and superior and the level below, and inferior level above. Again, here we are talking about indications, so it's mainly for severe deformity and fixed deformity with correction needed of around 62% in the coronal and around 45% in the sagittal plane. Sook reported complication, overall complication of 35% and neurological of 17%, while Linky reported higher complication, overall complication, and lower neurological complication of 11%. If you are talking about, again, a study done by AO Spine, that neurological complication in posterior vertebral column resection around 13.8, while infection rate between 3 and 10%. Another tool that you can predict the neurological deficit in posterior vertebral column resection is the deformity angular ratio. Here we can see that in the coronal plane, the cup angle is 100 and it's 8 vertebrae. You calculate that by 12.5, and the sagittal, again, the kyphosis angle or kyphotic angle is 96 and over 10 vertebrae.
صدرك واحد كنت فيه كله.
So, and again, for the key point for this was you will get higher complication for neurological short kyphosis, or the total deformity angular ratio over 25. So if you have the total deformity angular ratio over 25, or in the sagittal deformity angle of 15, you get higher newer or a new neurological deficit complication. This is an example for the closing open wedge osteotomy, as shown, and it could give you up to 35 degrees of correction. The vertebral column decancellation, you would place your screws above and below, and they will do your pedicle as if you are doing cancellation of the pedicles, and the transverse process and posterior element, you keep only shell of body, and you it would act as a bony cage. This technique will make the bony cage a substitution of the cage. It has some sort of deformity or neurological deficit of 25% with permanent of around one of those patients. So if we're talking about patients with angular kyphosis and myelopathy, some studies would advocate of doing only decompression, anterior decompression, and instrumentation and fusion in situ, and this will halt progression and improve myelopathy for patients with significant comorbidity or patient with refuse as the risk of surgical procedure. Again, this is another study. The absolute contraindication for posterior vertebral column resection is more basic medical condition, as well as second patient and family would not accept the potential risk and complication accompanying posterior vertebral column resection, as mostly we see in our region. Here, a comparison between the Smith-Peterson osteotomy and pedicle subtraction osteotomy, as well as the multiple posterior wedge osteotomies. Here we can show that this pedicle subtraction osteotomy show higher efficacy and efficiency compared to Smith-Peterson and multiple posterior wedge osteotomy, but the risk of local biomechanical complication greater with multiple wedge osteotomy rather than pedicle subtraction osteotomy. Bleeding in more in pedicle subtraction compared to the multiple wedge and Smith-Peterson. The neural complication in that study was almost the same. Here we're going to see some examples of my practice. So this is a patient with congenital severe kyphoscoliosis fixed due to congenital. This patient actually completely refused any complication, and she said that she would not really accept having any neurological deficit. Then we goes with trial of distraction with some sort of facetectomy, radical facetectomy. Here we got the ribs out of the pelvis, less pain, and better overall sagittal rather than coronal balance. This is another severe deformity, fixed deformity. We can see a patient did accept complications. So here the vertebral column resection posteriorly all done with cage substitution and double rod at the osteotomy, mainly at the osteotomy site, with better correction for the sagittal alignment. Here, this patient again, we saw that fixed kyphosis with severe scoliosis. All those patients actually presented late in 30s, in early 30s, all those patients in early 30s. Again, here, multiple pedicle subtraction osteotomy done for this patient, and we can see better sagittal and overall same coronal alignment, which maintained and patient satisfied. Here we can see again hemivertebra, the fused segment as well as oblique takeoff with partial sacral fusion with a transitional vertebra and sacral agenesis, oblique takeoff. Required excision of hemivertebra. This is the preoperative planning, and osteotomy, 3-column osteotomy, and correction of the scoliosis. You can see this is the osteotomy, 3-column osteotomy, as well as the excision of the vertebra, as well as decompression. She had some radicular symptoms. This an example of, again, kyphosis. This is angular rather than being super rigid due to rigid deformity, but this is mesenchymal, as in Marfan syndrome. We know that the curve is multiple planar with ribs in the pelvis, severe pain, and we know that Marfan syndrome has, on top of the deformity, the dural ectasia with anchorage point really need to be studied carefully, and keeping in mind the need for alternative fixation way. Those are example for dural ectasia as seen for this patient. So this is a patient with monitoring and clinical picture. And this is post-operative where multiple posterior wedge osteotomies with anchorage point at proximal and distal with sublaminar ropes used at the lumbar area due to the severe dural ectasia. And this is the general standing picture afterward. Patient was significantly heavy. She gained around 10 centimeter of height again, with ribs all out of the pelvis. This will conclude my talk. I would like to thank you again. I would like to thank the organizing committee for the invitation. Thank you, Professor, and thanks for the Egyptian Scoliosis Society.
Walid, thank you very much. Very nice cases. And now we'll proceed for the next speaker. The next speaker is my shadow brother in Pakistan. Professor Amir Aziz is someone which I really cannot give him enough words, because sometimes seeing is believing, but when you go and see what he's doing, you even don't believe it. He's a professor of spine and orthopedic surgery in Lahore, Pakistan. He has a wonderful setup. Many surgeons working with him, and the load of work he's doing needs about 100 surgeons to do it. So Amir will present on an innovative technique for correction of severe scoliosis. Amir, can you proceed, please?
Bismillah ar-Rahman ar-Rahim. Thank you, Yusri. You are always very kind. I must thank the Egyptian Spine Society, especially Yusri and Khattab, for letting us into this August gathering. We've heard high-level stuff, but we have designed something which might also help Walid in these very difficult osteotomies that he's doing. Next. We have nothing to disclose. If you look at the historical mummies in Egypt, in Pakistan, we still see patients like this. And Percival Pott described this disease of TB. I stayed in the UK for 6 years and I did not see a single case of TB. Maybe Yusri saw some at Oswestry, but I did not at Oswestry nor at Stanmore. But in Pakistan, this is still the bane of our lives. We do at least 100 plus spine cases of TB in our practice. So what we thought, we are the biggest Alizarov center in Pakistan. We do about 700 cases of Alizarov every year for limb deformity. So my able AP Saad Ilyas, who will show you at the end how this device of ours is put in, thought that we should apply Alizarov to our most advanced spinal deformity cases. This is just to give you a history. Yusri very kindly sent me a paper from the 60s where the halo pelvic hula device were used. And this is what they use. They use nuts here to lengthen the spine and correct the deformity like this. But in this, the patient was unable to lie down. It was very painful and very tedious. And we tried this in our patients, but we failed miserably. This is the assembly. And the initial one had a pressure device at the apex of the curve. None of our patients was comfortable. The Steinman pins in the pelvis were inserted obliquely, tangentially, and they were very painful. So we thought, in fact, Saad Ilyas thought of this system where the posterior part of the body was left totally free. And instead of a full ring around the pelvis, 2 arches were used on either side with a halo at the head with 6 pins. The complications in the past, there's a whole list of complications with the halo pelvic device, but alhamdulillah, we have not had much. This is how we started. In Pakistan, you cannot practice orthopedics unless you know how to deal with tibial fractures, especially with the Elizarov fixator. Our traffic is such that it keeps us in business. So this is our modification. On the left is the traditional halo. You see the pelvis hula hoop here, and this is our device with an arch here with 2 6mm shunts in the pelvis without penetrating the muscles, a halo on the head with 6 pins, and 2 rods, one anteriorly and one laterally. And you can see the patient can lie down, walk about, and very comfortably spend his life. So this is the head assembly. The patient can lie supine. It provides a sturdy anchorage. There is minimal risk of infection because we do not penetrate the muscles. We'll show you the assembly in detail. And it can provide adequate distraction force in the sagittal and coronal varices can be affected. This is the head assembly with 6 pins in the scalp. And this is how the pins are put in with the patient lying supine on either side of the pelvis. And we'll show you our first case when we thought of this. I don't know if in Egypt you still see cases like this. This is a paraplegic patient, 15 years old, with this gross deformity of his thoracic spine. You look at the patient, they are cachectic and severely malnourished. And if you look at the MRI, you see the pus all over here. So we decided to try out this concept in this patient, and we put this assembly on this patient, and we started distracting 3 millimeters a day through the assembly here on either side in all the 4 rods using the Elizarov principle. And this is such a degree that it does not damage the neurological part of the spine. So with this distraction, in 3 weeks, you can see the anaconda spine became pretty straight. And then we decided to go anteriorly through a left-sided thoracotomy at the previous apex of the curve, taking the rib out, and 8 thoracic vertebrae, which were eaten away by caseous tissue, were removed, and this locally made titanium solid cage was put in with bone graft, and this assembly was left in place for about 3 months when it was taken off, and the patient showed neurological recovery and was able to ambulate after about 3 months of this surgery. So the anaconda spine, we thought we had an answer to deal with that. We had tried traction in bed. We had tried the halo traction with a mobile drip stand and the patient sitting up, but our patients just do not tolerate. In this procedure, we have extended the indications, and up to today, we have used this in 17 patients. Stiff rigid kyphoscoliosis, 11, post-TB deformities in 5, cervical congenital scoliosis in 1, and a specific type of C2 fracture we've just used it in 1 patient. And after correcting the deformity, then we have used posterior surgery or combined anterior and posterior, anterior alone, and the trauma is just being managed with the halo device. There has been a 60% improvement in the magnitude of the deformity in all cases. And majority of the neurologically compromised patients improved with this device. Unfortunately, 1 patient died of operative COVID a few weeks later, and we lost one patient. The rest have done very well indeed. To show you some examples, this is a post-tuberculous kyphosis. You see there are multiple vertebrae damaged at the apex. The patient is still neurologically intact. So we put them in our device. And this is how these children can walk with the device in place. They're very comfortable, as you can see. And this is when the deformity was corrected, and then this patient had corrective surgery posteriorly, and he's doing very well indeed. Just to show you these, in Pakistan, the doctors also do not advise the patients properly. There are very few people doing these scoliotic surgery, especially surgeries of the spine. Most of these patients are extremely poor, and unfortunately, they are ill-advised, they lack education and resources, so they come very late. We are trying to request our colleagues to at least send us poor patients so we can spend something out of the pocket early on and hopefully decrease the complication rate and complicated surgeries in our patients. This is the kind of curve that I'm talking about. Waleed showed some cases where he did some very nice major surgery, but we put them in our device and look, they straighten out very well. And then the corrective instrumentation becomes much easier. And this is the patient walking about, laying comfortably at night in this device. And this is him walking in the park using his mobile phone comfortably. Similar case, mostly post-TB correction, and then PVCR done in the same patient. This is the patient that takes the cake. This is an 11-year-old girl with this kind of scoliotic deformity of the cervical spine. Believe me, I had requested most heavyweights in cervical spine surgeries across the world, and I got front, back, front, different kind of instrumentation, which was beyond me. So we tried our device in this girl. We did a posterior release of the congenital bony bars and distracted this child 3 millimeters a day. There was a huge risk of diplopia also in this patient because of the long-standing scoliosis torticollis in this patient. But this patient now, mashallah, this was the deformity. Look at the fusion, and we resected the pedicle on the convex side and the bony bar on the concave side, and then put our device, distracted it. And after 6 weeks, she was completely straightened out. Look at her now. Look at the quality of life. Look at the smile. She's so full of life. Look at her picture on the left, all made up. So I could not think of doing anything else except this one. And we sent this to Max AB as well, and who thought that this is the way to go in these children. This is her completely off the collar and the device, mashallah, looking pretty good. This is the latest fracture, C2, that we received, neurologically intact. There is some longitudinal split as well in the C2. So I did not have the courage to do an ACDF in this patient. And so we put him in our device. And the best part is this device is that when we put it, you see the picture on the left, the head was slightly crooked. So then we adjusted it without anesthesia, and the versatility of the device is in front of you. He's ambulatory. Hopefully at 6 weeks, the fracture would have healed and we would take the device off. Look at the comfort of the patient, and they are very comfortably able to go to sleep as well. So we've published the first case in the Surgical Neurology International. And now we are going to publish this series of 17 patients and hopefully expand the use of this device in our setup. The total cost of this assembly is about $200. And we've had some very encouraging results without any complication at the moment. My colleague, Dr. Saad Ilyas, who's my able assistant professor and the Alizarov lead in our setup, is now going to tell you how to apply this assembly. Saad, over to you.
Can you all hear me?
Yes.
Hello. Thank you, sir, for giving me the opportunity. Let me quickly jump on to the topic. We apply a halo ring using 6 pins, not 4 pins. And at the standard place of standard locations, 2 anterior pins are placed on the lateral 1/3, above the lateral 1/3 of the eyelid, 1 centimeter above, and 2 on the posterolateral part and 2 laterally. This is how we connect our halo ring. Let me tell you, all the components of this device are from a standard Alizarov set. We have not customized anything. Now, right now, as you can see, we are making an entry at a supraacetabular area from using a first awl, and then a blunt awl is used to make the track. And then using a ball tip, we mark the depth, and then a 5 millimeter is your taper is 5 millimeter, 6 millimeter half pin is used in the adults and 5 millimeter in the children. Sir, can you please pause over here? Can you please pause? Give me 1 minute. Can you please pause the video? Thank you, sir. Can you please move back 1 minute so that I'm caught up with the speed? A little bit behind, since I do not have the control. Yes, here, as you can see, this is the area of a supraacetabular placement. We use the site of anterior inferior iliac spine. We mark the site using a SIAM, and then using at that location with the starter's awl, a sharp starter's awl, we mark the entry, and then we extend the entry using a blunt awl. And after that, we pass a 6 millimeter tapered Alizarov half pin to that area. Sir, please, can you continue? Yes. So now, here you can see in the supraacetabular area, 1 half pin has been passed. The other half pin we passed in the ilium bone, and it is about 10 centimeter posterior to the anterior superior iliac spine. This half pin is passed in a similar fashion, first using a sharp first starter's awl, then a blunt awl, and then the length is measured using a sound, and we tap it using a 5 millimeter tap, and after that a 6 millimeter half pin is passed in the adults. The benefit of these 2 points is that they give you a significant angle for a multi-directional fixation, so that when we pass the 4 chance pins, it gives you a very sturdy construct. Then an Alizarov arch is connected to these half pins using Rancho cubes and posts. All of these components are taken out from a standard Alizarov set. We do not customize anything, and the cost is around $200. As you can see, both of the Shan's half pins are connected with an arch using Rancho cubes, and after that we connect the 2 arches to each other to make a C ring. And after that, both the pelvic part and the halo part are connected using standard 8 millimeter threaded rods. And we apply 2 plates, one horizontal and one vertical, to connect the threaded rod with this halo ring. And we distract the assembly from the halo part. From this part, we distract the assembly. And the beauty of this fixator is that it can we can add anything we want. In this patient, this is a assembly applied to a trauma patient, and we wanted a sturdy construct. So we applied connecting bars between the threaded rods. So the beauty of this assembly is that we have retained all the versatility and the modularity of an Ilizarov fixator. We can apply hinges whenever needed. We can increase the strength of the construct by increasing more than one threaded rods. We can connect the threaded rods with each other. So the beauty of this assembly is we can devise this assembly on a patient-to-patient basis. Patient is able to lie supine, and we can do a lot of things. We can correct the deformity, use it to stabilize our fractures, a lot of things. Thank you so much, sir.
Thank you. Thank you very much. Shukran. So fire away, please, now questions.
Thank you so much.
Thank you very much, Dr. Amir and Dr.
May I ask?
And we'll proceed for our next presentation, Navigation in Complex Spinal Deformity, presented by Dr. Salahuddin Khalifa. Dr. Salah is an orthopedic spine scoliosis surgery consultant in Abdallah Medical City, Mecca. Can you please proceed with your presentation?
Yeah, sure. Thank you very much for the invitation. It's really my maximum pleasure to join Egyptian Scoliosis Society again. Last year it was there, and before that in Luxor as well. I have a lot of friends there. Inshallah, next year we'll be together. And also here in Saudi Spine Society, we love to have all of you. If we're still discussing, the meeting will be in person, so we can break the COVID crisis, inshallah. So it's really difficult to speak after Prof. Amir, and really I'm speaking about something. It's really an important tool, but maybe today we need to discuss, maybe in the panel discussion later on, about really how to implement those technology in our, let's say, Middle East countries. Because, for example, in my country, in Saudi Arabia, I'm working in Mecca. We have this navigation unit since almost 10 years. And among 3-4 cities in the western of Saudi Arabia, we have like 3 or 4 machines. So it's really something not easy to implement, and it's really costly, the maintenance. And many surgeons, they like to go away from their navigations because they used to have their training and their fellowship and their career, all their career with the fluoro, and they have really magnificent results. So this is really important, and maybe this is a chance from the Scoliosis Society and Egyptian Scoliosis Society to have some questionnaires, studies about is really how can we implement this technology in our countries. Maybe in the future it will be more cheaper, more cost effective, and this is really important. So if I'm going to talk about navigation, it's something like a tool that improved and developed over the years, like the iPhones, like the new technology. When we were there, it was very important and very effective and high benefits with the Nokia, for example. But nowadays we have like more benefits from the new technology. So this is really important, like from the CR, then we have the navigation, city navigation, and now in the future, this robotic maybe will be in each place somewhere. If you go to the PubMed and just put spine navigations, you will have like more than 1,500 at least results of a lot of studies and a lot of articles about navigation. So something is going on, but let's be realistic. This is what I was speaking about, the cost effectiveness, especially in our society, in our Middle East, let's say, and in our area. So and I love to have the feedback from the audience. So if just to summarize my lecture in one slide, it will be this slide. If deformity alters anatomy, especially in the complex and in scoliosis, kyphosis, and in small pedicle sizes and shape. Usually you will have a lot of pedicle screw in one case, so it will be overwhelming with the fluoro. So if you have some tool that will navigate and will make your life easy, more safe, more accurate, especially in the concave side, sometimes you cannot find any pedicle there. Spinal cord position as well. Greater corrective forces. So we need a lot of forces, and a lot of forces needs good purchase, good tools, good pedicle screws, good purchase to the bone. So this is what I really benefit from the navigations. I used to start my navigation since my fellowship in Germany, 2013. So it's over like 8-9 years I'm doing navigations, and really the corrective forces, I'm not afraid of pull out of the screws after good screws purchase in the bone. Safety, accuracy, expansions of indications. So you can do a lot of things with the navigation, not only the instrumentation, you can help you in the VCR and in your Pontius tutomies, like what Dr. Walid before said, and it's like extra option, and always surgeons, they like to have many options. So it's very nice if you have a navigation tool with you in your difficult surgeries. And quick, this is a question with the learning curve. So at the beginning, you will find some workflow, slow of the workflow there, but by the time, it will be really quick and fast. The sizes, the measure, I don't do, rarely I'm doing like CT pre-op. So I'm depending on the sizes and measures during the surgery with the navigations. Some dopamine, if you are doing the navigation, I will show you some slides, you will be really happy and putting in very difficult screws. And also it's confidence. It's like someone going to the surgery with a senior mentor with him. So the navigation is a really very good friend for that. So, and always we are talking about the malposition and the accuracy of the screws. Maybe a lot of articles I will show you about the accuracy, but at the end, we will know that accuracy will be much better in the navigation, like the CT scan comparing to the X-ray. Cost effectiveness. So this is a study done in the orthopedic journal like 10 years ago. And they said in the heavy volume centers, it will be cost effectiveness. But let me just go away about the cost of the machine itself, the cost of the maintenance, because it's really sensitive and might be broken and need some replacement machines, and we don't have those stuff, and sometimes you cannot depend all your life on the navigation. It's very nice to have it, very nice to work on it, try to use it, and but really in our area, it's something really important to be discussed and to be thoroughly studied, and we need researches and more researches. So always to summarize the cost effectiveness, all the people they are talking about the vascular injuries and neurological injuries and the impact of any complications for those patients for life, like if they are paraplegic and the country or the government will pay for the rehabilitation, and it's like a long story. But if someone is doing like 100 cases and he's having 2-3 complications, so is this worth it to buy like above $1 million machine and with high cost for the patients as well? So this is really a good topic. This is what really I want to send this message during this presentation, that the cost effectiveness, we need to study this very well. Otherwise, the perforation grades, we know all about this, and a lot of studies about this. And sometimes even if you have some medial breach, like less than 2 millimeters or lateral breach, this will be acceptable. So not all patients, we are re-operation for those patients. The tragic complication, which is really rarely in going in the aorta, and I don't think nowadays in the modern fellowship and subspecialties and the heavy training, heavy studies, heavy courses, I don't think we are seeing such cases like this, but this is reported and in the literature in the aorta, and this is tragic, sometimes even up to mortality rate problems. So a lot of evidence of accuracy. Maybe I'll go quickly through that, and someone, if this recorded, can go back and read those articles. Always they are speaking about the malposition with the meta-analysis, and its favors the navigations. Insertion time, they are really favoring long time in the navigation. But if you go to the new studies, the navigation tool, the improvement of the technology, and improvement of the workflow, especially if the people they are doing. And I think this is a very, very good message and important advice from Professor Bernard Meyer. He's saying do navigation in each case, even the simple cases. Why? Because if you are doing freehand in all your cases, then in the difficult cases you want to do the navigation, then you will stuck there and you will have long time, and you will have problems with the navigation. Then you will go out from the navigation and you will say this navigation is not good. So this advice is really important. If this facility is really available in your center and you can do the cases, the trauma cases, the scoliosis cases, and those even simple cases sometimes like lumbar fusion or something with navigation, and you and your team, so you have a quick cases and quick access and quick safety, even good results with the difficult cases. This is another systemic review, and can show how much the accuracy rate in the 2D and in 3D in all spine regions and thoracic spine. And you can see how the thoracic spine is really up 60 to 70, and with the mean around 60, and with 3D navigations above 90. So really there is significant. We need more studies still. The evidence is not enough, but it's really logic. Sometimes it's going with the 3D navigations. So the pedicle screw placement as well without navigation, the accuracy, and we have many searches and research about this. I can summarize all of this in just one time. Blood loss sometimes. This is interesting if especially if it is long surgery. So sometimes you will have more blood, and this. So the group of non-navigated people, they will argue with us about this especially things. So if I can summarize just the accuracy thing in one slide. So just to move to another things. This is another meta-analysis, best evidence for So the freehand accuracy, it's around mean 85%, which is good. It's not bad, the freehand. The fluoroscopy, it's jumping to 90%, and CT navigation to 97%. So maybe the group of freehand, they will say, okay, it's not like a big difference between this, but sometimes one revision case will make your life disaster or make the patient's life disaster. So rate of revision for surgery, it's less than 5% if you summarize all the studies, and for the rate of revision for navigation is less than 1%. So sometimes you have like only 1% between two. So why to bother with the navigation? So it's really a big question, especially in our area, as I said. Always the pedicle instrumentation, it will be the bulk of the navigations, but with the technology, more technology, we are doing more stuff with the navigation like the TLF. Nowadays, I have this really workhorse, the navigated Midas. I will show you some videos today. I was in the OR with a really difficult case, so maybe if I have time. So this is the concave, and nowadays I'm going with the navigated Midas or my navigated speed drill, close to the cord without any like fear from hitting the cord or doing any problems. So for example, this case here, you can see I'm going with the navigations. Maybe this pedicle is not is quite good, but I will show you some videos of my surgery today. Just now I came from the surgery. So for example, this case, this is also from the literature. You can see in the severely deformed cases, the surgeon is standing in the left side of the patient, and see how much divergence he's going. So sometimes this is really difficult with the freehand, especially in the revision cases. This is the frame, technical issue with the framing. If you are away from the frame, so the perforation will be more. Yeah, this is from today. So for example, I have like this slit pedicle. So this is with this dural ectasia. So it's really difficult, but I'm now hammering, happy, my assistant is holding, I'm hammering the stuff till I found like a canal, and I'm going there, show you the screw. Then I'm navigating also the pedicle screw. I'm going through this one till I'm having a nice screw inside with really good pressures. So this is really something, if you have this tool, it's really something very useful, and we can spend a lot of time in discussing the beauty of the navigation. But as I said, it's really maybe those slides or those analyses will help you when you are discussing with the administration at the hospital, because I don't think there is any spine surgeon will refuse the navigation, but it's something like political, economic impact, and we are doing such cases like this with this. So some bad or the poor side from the navigation is the cost benefits. As I said, it's need to be still studied, or maybe in the future we'll have some cheap machines doing the same job of the high cost. I need to say it's high cost. And even me in Mecca, if I want to renew my navigation after almost 10 years, we have the navigation since 2011 or 12. It's really something with the protocol, with the bureaucracy, it will be not difficult, not easy. But sometimes in the West, because all those studies, they are coming from the West, they are having like in one center, like 4 or 5 machines. So it's something we need to do it. I'm really pleased with the presentation of Dr. Amir and Dr. Walid, because those are the things is realistic more. Radiation to the patient, this is something also important, but all with the machine now, we are getting less and less and less long OR, especially at the beginning. So this is the question, if you have a chance to get a surgical tool that would let you do the primary revision procedure at the same intervention opportunity and high safety and accuracy among all other alternatives, a great technical support to your advanced complex spine deformity procedures. So what would be your answer? Thank you very much. This is my surgical OR. It's like you are in the space. Now everyone is going to the space. So we have the beautiful space here in the scoliosis cases with the navigation, a lot of machines, and thank you very much.
Dr. Salah, thank you very much for your nice presentation. Our next topic will be how far is the mesh to osteotomy? And your friend, Dr. Mohammed Mishtawi. Dr. Mishtawi is a professor of spine surgery in Asyut University.
Dr. Sharif, Dr. Mishtawi has something
Yes.
on emergency cases. He apologized in order due to emergency case. So we can
okay, so
two questions.
we'll proceed with Dr. Samer. Dr. Mohammed,
good evening.
Okay, Dr. Sharif.
Dr. Samer.
Yes.
Yes, you're here. Dr. Samer Sami from Alexandria, the spine consultants, and he will talk about the revision, scoliosis, pearls, and pitfalls. Please proceed, Dr. Samer.
Okay, can I share my screen?
Yes, please.
I don't know where can I share it? I think it's not easy here. Okay, here it is. Is it available? Yes. Yes. Good evening, everybody, and thanks to the organizing committee for the invitation. When we are talking about revision scoliosis, I think anyone talking about revision, I think any one of us doing a scoliosis surgery, it is like doing a major construct. For example, like this dam, this Francisco Dam in the early 20s when it was built and suddenly broken down with a great disaster. The same thing if you do a scoliosis surgery and you find yourself post-operatively, if you do it or some of your colleagues do it and you have to go for a revision for a case like this. I think it's a major construct and you need to do a revision for these cases like this. Doing cases like this need very good preparation. When I tried to analyze why surgery in scoliosis failed, I found that there are many issues that can be causing the failure of surgery. It might be a preoperative cause, like planning your surgery, which is a must. Because if you do a good analysis of your X-rays and MRI, you might face many complications. Also, intraoperatively, surgical technique, which type of reduction technique you use, managing soft tissue, aggressive maneuvering, and the destruction of tissue might affect. Good irrigation to avoid infection, which was very common in the past. Good alignment, which we achieved with good technique used for reduction and the using of instrumentation available to achieve good correction with safety for the neurological system, and preparation of the bed of graft to avoid pseudoarthrosis. The post-operative factors like infections that affect surgery and you do revision, pseudoarthrosis is one of the main factors, and the fracture of the rods, implant prominence, and imbalance, which is due to where I stopped in the upper end vertebrae and the lower end vertebrae. So when we are going to assess cases of revision, Marcio Campos, when he assessed why revision, he found that the main causes was mainly hook dislodgement and pseudoarthrosis and the progression of the curves adjacent to the main curve correction. And when he made a literature review, then in the early ages, they found that dislodgement of the hooks as the main instrumentation and infection was the main causes. But with the advancement of instrumentation, they found that the other causes, the adjacent segment disease, PGK, and those factors were more common nowadays because the development of new techniques and new instrumentation with low profile. So when we are assessing why failure happens, especially, for example, rod fracture, screw fracture, pseudoarthrosis was the main cause. And this because we have to deal, as we all know, for deformity and spine is a 3D construct, and we are dealing with it. We have to deal with it as 3D, not a 2D construct. You have to carefully assess the coronal balance. You have to carefully assess the sagittal balance, the curvatures in the coronal and sagittal factor. Pseudoarthrosis will happen because there is a micro motion. We have to respect this micro motion, and once happening micro motion, pseudoarthrosis will happen and illustration failure. As I always say, is in fixation, either in a short segment fixation or a long segment fixation, it is a race between fusion and loosening. And once fusion happens, your instrumentation will be under less stress. As long as there is no good fusion, your instrumentation will be under high stress and we will have loosening or fracture of the rods or cage. Early good correction is acceptable, and this is acceptable. We found it in most of the cases, even with the cases like the single rod technique. But once with time and failure of the system, you will found failure of later on. Preoperative assessment must be done carefully in revision surgery because you are going to deal with a very tough case, a very long duration case. So you don't have any choices to do is the best to avoid a third more difficult case with more hazards. For example, which type of curve is available? According to the link classification, you have to carefully assess all the curves, primary, secondary, look for the proximal curve, distal curves, where to stop. Upper end or lower end vertebrae is a must. Assess the coronal and sagittal. Type of osteotomies you have to use. All these issues you have to be prepared very well pre-operatively. You are going to go intraoperatively as if you are going for a war or something, and you are all your equipments. For example, in this case, this was in the first. This image have been in the early of the pre-assessment. And as the patient, and when the patient do the surgery, the surgeon didn't look for this X-ray. He just go for this, I think, it's not me, but one of our colleagues. So he stopped at L2, which is far away here from the midline or the central sacral vertical axis. So when the surgeon did the surgery, he did it in a manner that is not professional that much. So the failure appeared in the fracture rods and the fracture screws and pseudoarthrosis. And as you see in the sagittal plan, there is hyperlordosis as compensation because of failure of the system. So another thing, this is not a revision, it is a fresh case. If we see it is just a linky one case with a single thoracic curve. But when you see at the sagittal plan, you found a significant kyphosis here. So if you are going to deal just only with the scoliosis, you will find that you can stop at D4, for example, or D3. But if you have to deal with this kyphotic issue to avoid post-operative PGK, you have to go upward to D1 or C7. As you see here, if you go this is the patient post-operatively, because you have to go up to deal with post problem to avoid another surgery later on in a very critical area like cervicothoracic region. When you are planning revision, you have to assess why failure happened, as I mentioned above. When you know the cause, you will find the solution. You have to prepare your set of removals of set. If you know the previous system, when you use it, it's easy. But as you know, the patient in Egypt, for example, travel from area to other and go from surgeon to other and use many systems available in Egypt. So you don't, most of the time, you don't have the information and registration of the system used in the patient. So you have to use system like this with multi-size of set screws drivers that can be used. It is very important and very nice system available in some companies can afford it. You can use it, and even the broken screws can be removed with this system. Prepare your set very well using the burr. The burr, for example, in a case like this, without a burr, it will be difficult to do the osteotomies, to remove the wires, to remove the rods, to do good dissection exposure. So I think burr saves time and blood for sure, because avoiding excessive manipulations that cause bleeding. Number 1 and 2, as I always say, the anesthesia team is a cornerstone in revision surgery. If you don't have a very fit expert in scoliotic surgeries, anesthetic, especially when you are doing in insurance or in university, please postpone your case, because this case needs a very, very fit and excellent anesthetist to do good manipulation with hypotension anesthesia, good perfusion, and good blood control. If you don't have it, please don't do surgery with any young anesthesia, or not, even if a professor and don't know how to deal with a scoliotic surgery, please check and choose someone who is very expert in anesthesia. 2 better than 1. This is very exhausting surgery. It might take 7 or 8 and sometimes 12 hours to do this surgery. So 2 is better than 1 in these cases. Staged surgery, a very wise decision. If you have lost blood too much and you might face this situation, you can postpone it and divide the surgery to save the life of your patient. As I will mention forward, bleeding is one of the main obstacles in this issue. Operatively, you have to deal with bleeding by good hemostasis meticulously. Any bleeder, even if it's a small one, you have to cauterize it to avoid excessive bleeding. You can save many blood. Tranexamic acid is a must. Alignment using the osteotomies with Schwab technique, osteotomy classification. Use whatever you plan to do to achieve good correction. The new quick standing rod technique to achieve good coronal and sagittal balance, and do good contouring for the rods to achieve also good correction. Prepare your bed for avoiding pseudoarthrosis, especially in the revision cases, by using the burr to achieve good bed for the graft, using bone substitutes, and take good graft to the patient. Vancomycin usage in the tissue post during closure significantly reduce the case of infection post-operatively. There are many types of osteotomies, as you all know: posterior column osteotomy, PSO, PCCR, which sometimes you have to use it, and the kickstand rod technique. As you see in this case, these screws have been removed. The osteotomy have been done using just pointed osteotomy, and correction was achieved. When Stephen Richard and others did the review about revision surgery in 2006, they found that the revision surgery and reoperation rate around 12 to 14%. And one of the causes was mainly, as I mentioned, infection and pseudoarthrosis and dislodgement. The same team, after 5 years, did the same review again. They found that with evolution of the implantation system and using of prostheses and bone substitute and enhancers of fusion, they found that reduction of revision surgery to about 7%. My pitfalls that I faced personally in my experience with revision surgery, the 2 main pitfalls that I advise everyone to avoid is bleeding. You have to You yourself monitor the bleeding, even if you have a good and efficient anesthesia team, because sometimes the anesthesia team tell you it's okay, go ahead and continue your surgery. If you have exceeded 2.5 or 3 liters bleeding, I recommend you to stop and postpone. And I have tried it twice, and I go out relaxed, and the patients go well. And 2 weeks later, I go for a continuous surgery, and it go well. One time I have the risk for the patient, but it was over the edge, as I mentioned, and with a miracle, the patient survived. Exhaustion is expected for a 7 or 10 hour surgery. So using 2 experts in these cases is a must. It is not time for learning or teaching your fellows or residents how to do a scoliotic surgery. It is a very difficult surgery. You have to be hand by hand with another expert, do it together, because you have time to remove the old system, do dissection, osteotomies, and application and correction. In my methodology, I have 11 patients with 9 females and 2 males. All were decompensated. 9 of them were significantly with single rod technique. 9 have hardware failure. I did 2-stage operation in 2 cases. All cases used PCOs, and 2 have posterior vertebral column section and kickstand rod technique in 2 cases. I will present some cases. This is a female patient, 17 years old, operated first time for 5 years ago, link 1B with a COP angle 56 with a correction 20. This is a patient pre-operatively, as here, just here post-operatively, as we do, we just pointed osteotomy, and here is the correction post-operative of the patient. As we see here, she has a broken rods and using the Isola old system, and here's the patient post-operatively. Another case, 26 years old, first operation 2 years ago, Linky 5, COP ankle 55. This is the case I mentioned before, and with broken rods and broken screws with pseudoarthrosis. We did revision for this patient. This is a case, as you see, some also there is a pseudoarthrosis at the site of the cross links. Here is the patient post-operatively. Another case, 14 years, with first operation 1 year ago, and she had a global imbalance about 2 months post-operatively. She came to me with a sagittal and coronal global imbalance. I used the kickstand rod technique to achieve good correction, to distract at the coronal balance, and this is a patient post-operatively. The revision researcher tips from my point of view is good planning and good preparation of your cases. Anesthesia team is a cornerstone. Hemostasis also is mandatory. Monitoring of your patient, if it's available, is a must. Osteotomies, choose a good osteotomy and the correction technique you can do. Don't hesitate to stage your surgery because it is a must. My take-home message: revision surgery is very tough. Surgery need good planning and good preparation. Peripheral anesthesia, as I mentioned, 2 experts, again, I said is must. Avoid single rod technique, and thank you very much.
Thank you very much, Dr. Samir, for your very interesting topic and sharing your challenging cases with us. Dr. Muhammad Fawzi, do we have questions for Dr. Amir Aziz? Dr. Fawzi?
Yes, Dr. Sharif. Thank you, Dr. Samir, and the whole panel for their presentations. And I'd like to ask Professor Amir Aziz, what is the advantages of your technique over the hollow gravity traction?
Thank you, Muhammad. Can you all hear me?
Yes, we can hear you.
We found that our patients were not very compliant with the halo gravity. The control was not as good, and especially when they become recumbent or when they want to lie down, it cannot be maintained. Plus, the standard recommendation is up to 3 months of that, and we could not successfully use it. We find this much easier, more controllable, and in any posture, the traction is maintained.
So there is no question of this being lost. And it's almost pain-free in very young patients and in adults as well. We showed you some examples from all age groups. So that's the reason we found it much easier and more controllable than the halo gravity traction.
Okay, thank you so much.
Dr. Amir, I have a question.
Please fire away.
Why do you use 6 pins in the halo traction? We usually use only 4. What's the advantage of 6?
We find that you do not have to tighten them as hard as in 4. You do not have any soft tissue damage when the force is equally divided in 6 pins. We used to use 4. We used to have a lot of problems at the pin sites infection wise. Remember, in our part of the world, the weather is hot and the infection rate is pretty high. Most of these patients are very poor. They don't even have fans in their households. So it's much easier if we exert less pressure than when we put them in 4. But this is just our experience. I do not have any biomechanical scientific data to give you at the present moment.
Can I add one part to it, sir?
Please.
Actually, the AO also recommends that you at least use 4 pins, and up to 4 to 8 rings are 4 pins are recommended. This is the recommendation which is mentioned in the AO manual.
Okay, so.
Okay, thank you so much, Professor Amir and Dr. Saad Ilyas, for your nice technique and the presentation. And I think I encourage all the attendees to write any questions and the answers in the Q&A box, and our great faculties can look after your questions. So we'll continue with the program, and the next speaker will be Dr. Wael Al-Qasim. Dr. Wael Al-Qasim is an spine consultant originally from Syria, working in Erbil, and he will introduce his experience in managing intracanal abnormalities and deformity cases. Dr. Wael Al-Qasim, happy to have you. Please go ahead.
Thank you, Dr. Muhammad, and thanks for invitation, Dr. Sharif, Professor Yusri, and I'm start to sharing my and one moment. I don't know why it's not get to sharing.
Well, you open the presentation, and from
yes,
the
I
green
opened
button.
It. Yeah, I already am doing this the same. I don't know why it's not working. It was working. So could you move to the next lecture, then I can fix it, Dr. Muhammad.
Okay, well, so Abdulaziz, the next speaker will be Professor Dr. Paron Lunar. Paron is one of the spine deformity consultant leaders in SRS, and he is professor of orthopedics and spine in Mount Sinai Hospital and Medical School in New York.
It's my pleasure
Paron
to be joined.
is recording his presentation, and we are happy to have his records. Abdulaziz, please start,
It is
Professor
my
Parlin
pleasure
presentation.
to be joining you, my colleagues, my dear colleagues and friends in Cairo. I'm sorry I couldn't be there in person or to be able to attend the meeting. I'll talk to you today about neurological safety in spinal deformity surgery. And one might title this Confessions of a Spine. So we'll speak about risk stratification and counseling of patients, the role of neural imaging and mitigation of risk, as well as intraoperative factors and postoperative issues that can arise. And clearly, neurological safety is of utmost importance for the family, whether they're in Cairo or New York or wherever else. And really, our patients want correction, but they also want to be able to walk after surgery. And when that doesn't go well with our legal system in the United States, we see tremendous monetary awards, $45 million, for example, in this patient who was paralyzed and subsequently died with an untimely death. And neurological deficit, really, parent and patients are concerned in this paper by Keith Gridwell and others. So we'll look at a number of factors that are pertinent here, including patient characteristics and then the surgeon, resources, etc. And whether we're in a underserved area without infrastructure, it's important that we bring our team, and neural monitoring as part of that wherever we are practicing. Otherwise, the patients are placed at excessive risk. So neurological injury can occur as a direct injury, which hopefully is relatively rare, screw placement being errant, an osteotomy that may result in a direct injury to the spinal cord, translational malalignment that can occur, and correction of large curves, stretch or ischemia to the spinal cord. And then there can be radicular issues from foraminal stenosis or pedicle screw breach, brachial plexus, and delayed onset ischemic compression lesions. Of course, intraoperative positioning for prolonged periods of time can result in ischemic optic neuropathy, and I won't really spend time on that today. So really, we can stratify by risk by disease itself. Congenital scoliosis is more likely to be associated with a deficit. The severity of the disease, in addition to procedural complexity, the focus classification helps us with this, and of course the surgeon. And we look at categories of disease. You can see that the stratification can occur in terms of who's at risk, spinal cord, nerve root, etc. Kyphosis being the highest risk. And then in terms of the pediatric scoliosis patient, congenital scoliosis leads to the top of the list in terms of specific risk of injury. And we will look at the Scheuermann kyphosis patient versus adolescent idiopathic scoliosis, and we've published on this. The neurological risk is really significantly greater for kyphosis. And although, fortunately, in our series, compared to a larger series of adolescent idiopathics, really the issue is more of intraoperative monitoring change in one patient, which the procedure was aborted and then the patient returned to OR without an event. And in one case, cervical radiculopathy versus one patient in the AIS group had a screw that was misplaced. So the numbers are relatively small if we look at moderate curves, but there are more severe cases, and clearly the risk ramps up with that. And Dr. Boachi and team, we were part of this, developed a complicated equation that took into account scoliosis, kyphosis, the type of pathology, and other factors, including the osteotomy, and came up with a grading system. You can see, but the most complex patients, 5, they're going to be very high rate, 42% of neuromonitoring changes, and a third of those patients with a deficit, with a complication, sorry. One can look at the angularity of the deformity. So the deformity angular ratio is very important with a coronal or a sagittal DAR. And for patients with a sagittal deformity angular ratio, taking into the curve magnitude divided by the number of levels in the curve, those are clearly more at risk with an angular kyphosis, 90% monitoring alerts from Larry Lenke's work. There can be approach-related issues as well, and some of this probably relates to the severity of the disease. This is an older paper. And the type of anchor that's used, pedicle screws. Again, historically, pedicle screws were associated with higher rates of problems, sublaminar wires as well. And these numbers are much smaller in more contemporary series. The nature of the resection, in other words, whether it's a true vertebral column resection for complex congenital, really impacts the risk of neuromonitoring changes, 44% for VCR versus a true deficit, which is very high, 17%, as opposed to a hemivertebral excision with substantially lower rates. Here, a hemivertebral excision, two separate hemivertebral excisions, and this can be scooped out with a temporizing rod. It's relatively safe as opposed to a complex vertebral column resection. And here again, we use a temporizing rod, and I'll emphasize this in both in this talk and subsequent talk. So in our experience in Africa with posterior vertebral column resections, we had a 22% rate of monitoring changes, spinal cord injury 2%, and nerve root 2%. So clearly, as we increase procedural complexity, the rates of neurological injury do increase. And perhaps we can mitigate the nature of the operation through using halo gravity traction preoperatively and improving deformity over time. We do a lot of this in Africa in our experience, and have done simpler posterior column osteotomies in lieu of vertebral column resections. And you can see here in this paper by Paul Sponseller, the controlled patients who did not undergo traction had a higher percentage for complex deformity of vertebral column resection versus traction patients. Only 3% underwent resection. We also know that the experience of the surgeon is important in determining neurological injury rates. And we wrote this paper, and the rates are half in terms of percentages in much more experienced surgeons, both for AIS and neuromuscular conditions. How do we develop proficiency? Through direct didactic education, through training, hands-on courses, mentored surgery, working with a senior and experienced assistant, and then gradually improving and gradually increasing the complexity of procedures one performs in their practice. And it's important to do a self-audit, to really look at yourself in the mirror and practice humility and keep your eye on the ball, as we say here in the United States. First, do no harm. And then you can graduate to the more complex cases. Preoperatively, our patients largely undergo neurological assessment, of course, and the patients have an increased risk of postoperative deficit when they start off with a deficit or a sick cord in particular. MRI screening we do fairly routinely now, but especially for those with preoperative neurological deficits, calf asymmetry, congenital deformities. We use it routinely in Scheuermann's and for early onset scoliosis, and of course unusual curve patterns and rapid progression of deformity for AIS. We found a significant number of patients in our Scheuermann's kyphosis cohort with abnormalities that prompted removal of a disc, for example, in this case, thereby we believe decreasing neurological injury rates. And this was an asymptomatic disc herniation in this patient. And so I won't go through all the details here, but very significant number of nearly 60% with neural axis abnormalities, disc protrusions, and 50% syrinx, low-lying conus, etc. And significant neural element impingement in five of the patients, as shown on the bottom. And the surgical plan in our series, 5% of the patients had their surgical plan altered by the preoperative MRI findings. So pertaining to the previous slide, we feel that preoperative MRI is imperative in many of these patients, particularly with severe deformity. Intraoperative spinal cord monitoring using multimodality approach is known to us all, requires total intravenous anesthesia. We can use a muscle relaxant during exposure, except if they're neurologically labile, and then we maintain motors throughout in that case. We feel that muscle relaxants help us to decrease blood loss and tissue trauma, as well as surgeon fatigue. We maintain the mean arterial pressure at 60 to 70 millimeters of mercury during exposure, and then raised to 80 during corrective maneuvers. We don't lower the mean arterial pressure if the patient has a sick cord. There can be monitoring, from a neurophysiological standpoint, but also if we see a precipitous change in blood pressure or heart rate, that can indicate that there's been a sudden spinal cord injury. We also assess, in addition to the physiological monitoring, palpation of the screw tracks, and we use evoked EMG. Fluoroscopy is helpful, but if advanced imaging is available, it's particularly helpful, including navigation. Our goals of neurophysiological monitoring are to prevent injury through timely detection and reversal of an impending neurological insult. And this can reduce the effect of neurological injury with early detection and appropriate treatment. I won't spend much time on this, but there are limitations of somatosensory evoked potential alone. You can have false negatives, and these are highly sensitive to inhalational anesthetics, hence the reason for TIVA. And here, this important paper and study shows the fact that SEPs often lag behind the motor evoked potential changes, and there's a significant risk for false positives. And in their series, motor evoked potentials were 100% sensitive in detecting early decline. And mean arterial pressure less than 60 was associated with change in the motors. When there is an alert, it's important to follow the checklist. This is available in Spine Deformity. Mike Vitale is the first author on this paper. And we can see changes even after using a hemostatic agent in the spinal canal, as we do here. Or you can put a thrombin-soaked sponge that may be impinging on the canal. And sometimes these agents expand, and you can see a change gradually over time. So the treatment is to remove the hemostatic agent, and then the motors and sensory monitoring improves and returns to baseline. When we're assessing screws, we must, first of all, use our anatomy, obtain orthogonal views with fluoroscopy. If a screw is non-harmonious compared to the one above or below, it may be too medial or lateral for that matter. And if you're not sure, you should remove the screw. We like to use evoked EMGs, although now with the use of spinal navigation, we're using less of this. But you should take 7 milliamps as a threshold. Anything less than that is circumspect. And sometimes you're going to have a low stimulation because of very small and thin pedicles. So it's important to look at the values of adjacent on the other side and above and below. And here is a patient without reliable monitoring with a neuromuscular scoliosis. And this patient had a screw that was a bit medial, and perhaps we did not appreciate that on the intraoperative X-ray. Fluoroscopy may have been better in that case. And again, today we're using spins, CT scan spins in the operating room, which are really very helpful. But here's a case where we've got that non-harmonious screw placement and it's stimulated low. And I think we thought we were okay, but that screw was medial. And sometimes there can be a normal stimulation and normal monitoring intraoperatively, but there can be migration if there have been multiple passes through that pedicle. And so sometimes it's best to leave that pedicle screw out. Here, I'll just spend a minute or two on a troublesome postoperative scenario of delayed postoperative deficit in this patient. We performed a VATS release and multiple posterior column osteotomies and left it at that. The patient had many changes in monitoring throughout the procedure. We did multiple wake-up tests, and the patient woke up fine every time. There was a delayed onset of paraplegia 20 hours following the placement of implants and the second stage. The implants were then removed and reimplanted 1 month later. And this patient has had improvement, but a persistent deficit nevertheless. The presence of delayed deficits we have reported on through a survey of the Scoliosis Research Society. 81 surgeons reported 92 cases, 63% occurring within 24 hours, and the most common cause was ischemic injury. The neurological recovery from compression related changes is better than that associated with ischemia to the spinal cord. And you can see some of these cases occurred beyond 48 hours, but the vast majority within 24 hours. And the breakdown of injury is shown here. Anterior cord syndrome and radiculopathy were most common. Ischemic injury and cord compression, as well as unknown, were the top causes. And 2/3 of the patients were taken back to the operating room. Some were delayed in that, and a third were treated non-operatively. And 3/4 of the patients underwent spinal imaging first. Complete recovery occurred in 41% and partial in 26%, none in 1/3 of the patients. So in conclusion, we are tasked with first doing no harm. And, we're faced with various disease and pathology states, different severity and procedural risk associated with these. It's important that we reflect on our own experience and go about training and education in a very deliberative manner. Spinal cord monitoring is crucial, and responding to alerts in a uniform fashion through a checklist. Delayed deficits are not common, but they can occur, so it's important that we maintain blood pressure postoperatively, especially in the very severe curves. Maintain a mean arterial pressure over 80, and if you're a spine surgeon, you'll have a problem. Thank you very much.
Thank you so much, Professor Paron, for the presentation. And back to Dr. Wael Qasim. Wael, are you ready?
Yes. Thank you,
Please,
Dr.
go
Muhammad,
ahead.
and sorry for the this technical. I just fixed it. Now, is it okay, Muhammad?
share your
not yet,
screen.
Wael.
Now it's okay. I mean the sharing.
Not yet.
I think it's good. Why not?
دكتور وائل استاذن
Yes.
حضرتك بس ممكن ندوس على شير سكرين.
انا عم سوي الشيرنج سكرين وعم اعمل شير، عم يعطيني الديسكتوب، عم يعطيني الاوبن سيستم بريفرنس، عم افتحها واوريدي انا عملت الزوم. اوكي
تمام. بس ندوس على سكرين بعد كده ندوس على شير، نضغط على شير.
I think Wael is outside right now. So, Dr. Hani, are you ready?
Yes.
So great. So we will continue with Professor Dr. Hani Sulaiman, Associate Professor of Orthopedics and Spine Surgery in Al-Azhar University, and one of the pioneers in spine deformity in our beloved country, Egypt. Dr. Hani will present his experience in managing neglected severe kyphoscoliosis cases. Dr. Hani, please go ahead.
Thank you, Dr. Khattab, for the kind invitation, and thank you for all the organizing committee for giving us this chance. Great meeting. So I have a case presentation of this 12 years old girl presented to me with this type of severe kyphoscoliosis. Her weight is 24 kilogram. She has no other comorbidities, neurologically intact, and her MRI whole spine showed no neural axis abnormality. Her pulmonary function showed severe restricted.
لو عاوز تبعت البرزنتيشن ليا.
Can you hear me?
Yes, Dr. Hani.
Yes, Dr. Hani, please go.
Okay. This patient was diagnosed with early onset scoliosis since the age of 2 or 3 years old, and she came to me carrying a huge amount of X-rays, CTs, and MRI. And I want to feature these 2 points of her deformity journey 6 years and 4 years before presentation. And this is a great evidence on how badly early onset scoliosis can progress over time. This is the current situation. She has severe scoliosis, 115 and 150 degrees. Her L5 is so much oblique on the pelvis. She still riser 0 and triradiate cartilage is still closing. And she has also severe kyphosis, 130 degrees. And if you look here down, this is exactly what we see in CT scan. It's because the obliquity of L5 on lateral view. This is her right and left bending. It didn't move that much with bending views. This is her body image from the back, and this is her body image from the side. To cumulate the risk factors, she has severe scoliosis, severe kyphosis, bad pulmonary functions. Her weight is only 24 kilograms, which is a huge risk factor because there is no simple solution here, and whatever you do gonna be a major intervention with expected significant blood loss for this body weight. She is still riser 0 with still closing triradiate cartilage, which means if you wait more, she will have more significant progression. So the treatment options. The first option that we all of us think about it, including myself, is the risk is too high, just leave her alone. And there is other option for this meeting. Yes, the risk is too high, but she is miserable and we should do something to help her. And if we want to do something, it is time now to do it because it will progress with more catastrophic deformity. So I want to leave you with these x-rays to help you decide what to do and help me with your planned fusion levels, what to do for this girl. Dr. Khattab.
Before proceeding for this patient, I will do traction under general anesthesia to assess the flexibility well. Plus, may I proceed for preoperative traction before managing this patient and decide the further management steps? Or I think Dr. Amir can do.
Yes, after having the lecture of Dr. Amir, all of us will use his frame.
Nice technique using
Hani,
the
we treat similar patients now with our Halo device. We've just done one today, 24 kilograms weight with 8 kilogram neurofibromatosis tumor subcutaneously in the posterior area. So we have removed the tumor, put her in Halo pelvic device, and inshallah, when she straightens out, then we will do a posterior instrumentation.
And you expect how long will be the traction, Dr. Amir?
Up to 3 months if required, but usually by 6 weeks, they usually straighten out enough to make things very, very operatable.
Okay, thank you. Any other idea? Shall I proceed?
Yes, please, Hani.
Okay. I did it all posterior. I didn't do any traction before the surgery. It is matter. This patient is like the traction is a very good option, and I will choose it as the first option. But the problem with such patients, the private patient need to be in the hospital for 2 days, and this was the quickest solution for her. I did it all posterior. I did bronchosteotomies at all levels and the instrumentation from T2 to L5, and this is her post-operative images. This is her 8 months follow-up. She's 1 year now after the surgery, and she's doing fine. This is a small comparison between her pre-operative and post-operative coronal balance. And this is her comparison between pre-operative and post-operative sagittal balance. This is her body image before and after the surgery. And this is her side view before and after the surgery. This is her before and only 10 days after the surgery. And this is 8 months after the surgery. She is doing great and she is extremely happy. Thank you for your attention.
Thank you so much, Hani. She became a nice lady. Good job. Well done. So back to Wael. Are you ready, Wael?
I hope so. I fixed it, and I don't know why it's not.
So, Hani, I think we'll keep the discussion and the questions till the end
Yes,
of
okay, but
this
I think
webinar. So, Wael, can you, Dr. Hani, please stop sharing your screen and Wael start to share your screen.
Now it's okay.
Here we go. Okay. Go ahead, Wael.
Yes. So thank you very much. Sorry for this technical point, because this is the device a little bit new. So this is why, and this is my first Zoom meeting on it. First of all, I want to thank you all about all this this kind of a program. It's a very nice program. Always I advise my colleagues that to attend this Egyptian Scoliosis Week. Always there's very good lectures, very tough cases, and I think it's a wealth to attend every year. I will start to talk about the intercanal anomalies in the spine deformity, and that we all know that this kind of anomaly for intercanal pathology, maybe the Chiari malformation, diastomatomyelia, type 1, type 2, tumors, tethered cords, etc. And I'm going to share this first case about these anomalies. I saw very tough cases have been already presented in this meeting. But this is a case with the neurofibromatosis, with intracanal tumors, very severe coronal and even in sagittal. Easily you can recognize that how the spine it's get very lumbar curve. With MRI we found this is dumbbell tumors. The dumbbell tumors, this is a part inside the canal and the part outside the canal. So we decided to do for her surgery. Usually what we used to do, even in such kind of anomalies, that we send this patient for the neurosurgeon. He will do the part, which is neurosurgical part. Then we will get back to this case. We will found there's no anatomy. It's very difficult to even insert the screws. And plus the already in this such kind of patient, as everybody knows, that the pedicles hypoplegic and the dural ectasia, which is make it very difficult to do. So what we are doing for this such kind of cases, we do directly all in one. So first we did if I ask it what you are going to do remove resection the tumor at 6 months, later on you will bring it again, or we can do all in one session. What we did first anterior release and put a grafting in every disc space for the 5 levels. Then I went back, removed the tumor, the intracanal and the extra foraminal one. Then we did the correction with some help with the interlaminar wires, because there was no place for putting screws. And maybe, as Dr. Salahuddin from Mecca said, that maybe the navigation will help in such kind of deformity. So this is her X-ray and her photos. Clinically, it's coming after the follow-up. It looks very nice in coronal and in sagittal regarding the hair deformity. And I don't know, maybe it will be a nice thing if we did also friendly growing, as she is 8-year-old. But for the neurofibromatosis, I found that it will fail so fast. If I move to another one, which is the diastomatomyelia, we know usually we found that the deformity with intracanal anomaly, usually it's very rigid. So in all my cases I have ever did, that I found it's very rigid. It's not coming so easily. I heard from a lot of professors, okay, you can skip the area which there is already had previous surgery by a neurosurgeon to remove the bumper, but I still do that. The correction is needed, even in very mild cases. So usually what we are doing, I put my patient, I'll do the planning for the whole surgery. I mean, the whole surgery, that the correction of the deformity, removing the bone spur, and this is in one session. What I'm doing, I will start to put the screws first. Then we do the laminectomy, removing the pore, If it's the bone part, it's more than 1.5 centimeter, I have to open the dura, make both dural sac in one sac, and then continue to do the all correction. Here we can see that this is the bone, which is splitting the cord, and this is removing it. And if you notice that already I put my screws before I proceed for the neurosurgical part. And during the surgery, usually we have some kind of bleeding. If the general situation of the patient allowed to me to proceed for whole correction, I will do whole correction and I will do it. So first I'm putting the screws, then I will proceed for the intracanal job, and then the correction. So what in general, in cases that we need osteotomy, such kind of cases that I've already seen, which with intracanal anomalies, how to choose the level of osteotomy, and that I will present two cases. This case that we found that there is diastematomyelia with tethered cord, and if you notice that there's a pelvis epicrotty very clear. You can see even in the upper dorsal fusion happening. So and the pelvis obliquity is not regarding to the discrepancy. So, and this is here the L1 diastematomyelia. Going back to the X-ray, that if we see that the L1, it's also the apex of the lower curve. So if you will choose to do osteotomy in this level for the correction, and when I'm saying osteotomy for this level, that I want to try to shorten the spinal column. This is in this technique we will avoid the deficit. So I will never do the osteotomy in the same level if it's the same level of the apex. Why? Because you will face a very massive bleeding. Plus, you will get mandatory CSF leak, especially if you are opening the dura, and the anterior CSF, sometimes it's difficult to control. You have to put maybe drains for 7 days, then remove, or maybe you have to do something else. So this is a hair X-ray. As I said, I will plan for whole surgery. I proceed, and this is the osteotomy level. It's just exactly below the L1. And you can notice that the domino, which is I closed my correction, I didn't put full correction because I want to make a balance with the previous dorsal fusion and this one. So if it's in the same level, I'm going to do the level above or below the osteotomy. Why? The bleeding less, the CSF less, the surgery time usually it's less. What if it is in different levels? So this is here the L2 and the apex is above. So I did the same with the screws, and then removed the bone pair, and I did the osteotomy in the apex itself where I can get better correction. So here I did the osteotomy on the apex, and this is her X-ray after the surgery. I think it's good coronal and sagittal. With one session, we did all the jobs. So if the split cord and the apex in different level, the osteotomy, it will be at the apex. But if it's in the same level, for me, for my experience, it's better to choose level above or level down. This will help. The key in this job, it's the teamwork. So we are now for the last 5 years, 2 spine surgeons doing such kind of surgery together all the time. This will make easier everything, as already mentioned. This is what was about the diastematomyelia. So what about the tumors? So this is a case, 13-year-old with the tethered cord, diastematomyelia, and a tumor. So here to the right, you can see that the tumor is clearly, it's dermoid, it's congenital, I know. From the MRI, it's clear. And what we did, and you can see even here the tumor, you can see the diastematomyelia type 1, and we did all the same. We put the screws, remove the tumor first, then remove the or correction of the point spur. In this case, it was less than 1 centimeter, so there was no need to open the dura. And I did all in one things. for me, till the moment, I found it's better than the cases that I received from other neurosurgeons, which they did just only the tumor and the diastema familia and sent to me to do the correction. It will be a very, very, very difficult to get the anatomy, and you need maybe some new technology devices in navigation to get the put screws or do your osteotomy. See, the last case with the tumors, this case with severe kyphosis, as I mentioned, usually it's very rigid. All this type of curves, even if it's small, it's usually rigid. So I need some kind of osteotomy. This is the girl. This is her shape, and because of, you can see that the deformity in the tooth, which is refer us that there is some cord problem. This is the tumor. You can see it's easily on the T2 of the MRI. Cathode cord also, you can see the cord, it's leaving, reaching to the S1. And what we did tumor resection and the correction in the same time. And I want to share this powerful technique, which is the joystick. You can see how it's make the correction. Just notice how it's come up, come down with some pointies, and it's give a very nice correction regarding especially the sagittal plane. And here clinical photos, and here's the x-rays, and this is for 1 year follow-up. Still the moment, I think it's very easier to me to do it, all this in one session rather to receive a patient from other surgery, which is, will be more difficult to do. Thank you very much.
Thank you so much, Dr. Wael, for your presentation and highlighting the importance of working in team in such difficult, challenging surgeries. So we'll keep the discussion till the end. And the last presentation for this webinar, but not the least, Professor Dr. Hisham Shakir. Dr. Hisham Shakir is a professor of orthopedics and spine in the Military Academy, one of the pioneers of spine surgery in Egypt. And Dr. Hisham will present a talk describing the effect of different types of vertebral release on the final amount of correction in adolescent idiopathic scoliosis. Dr. Hisham, kindly share your screen, and we are interesting to hear from you.
Dr. Muhammad, I'm very happy and pleased to share this meeting.
Hi, Dr. Hisham, share screen. Okay, sharing now. Okay, Dr. Hisham.
I'm going to start from the start. Just a minute. We got different types of vertebral release to get the final amount of the possible correction in adolescent idiopathic scoliosis. As an introduction, we know that scoliosis is generally treated by surgical derotation of the spine. A second goal is the hump or the rib deformity. Previous study evaluate the effect of surgical release such as discectomy, costovertebral joint release, and facetectomy, and costoplasty on spine mobilization and the overall contribution to the thoracic stability. Many studies studied the biomechanics of vertebral movement, and as most of the release is performed at the level of the thoracic vertebrae, because the thoracic vertebrae is different than the cervical and lumbar, and this is because of the presence of the rib cage and the costovertebral joints. This paper studying the biomechanics of the effect of rib head release on the thoracic spine motion. The intact costovertebral and costotransverse connection affect the axial rotation of the thoracic spine. and also affect the lateral bending of the spine. Why we do need release in scoliosis? Biomechanically, to increase the flexibility of the spine and correct the deformity. The biomechanic correction by examining the stress strain curve, we found that the yielding point and the fracture point of the cortical bone is too short to acquire enough deformation without fracture to correct the scoliosis. So the main work is through the soft tissue release in correcting and reaching the fracture point for bone. So we mostly use the soft tissue release in our correction to get the correction of the deformity. This scale testing the different materials and the effect of the deformation, we find that the tendon and ligaments are giving yielding to the stresses more than the bone. And this is the stress the scale. Here is the elastic zone, the yellow one, and here is the plastic zone, and this is the yielding point, and this is the break point. However, the vasoelasticity of the soft tissue can provide enough deformity correction without losing their integrity. But if the deformity is so severe and rigid, so we have to work on this soft tissue release to give more release than the yielding ability of the tissue. Types of the release we know in correction of adolescent idiopathic scoliosis is either posterior or anterior. We will see what is posterior. In posterior, we got the costotransverse release. This is one of the release. And the facetectomy. This is another type of release. The third type is working with the head, the rib head. So costovertebral release. And the last one is the thoracoplasty, which excising part of the rib, disconnecting the effect of the rib on the limitation of the spine derotation and movement. According to Zinferg et al., sequential costovertebral joint release resulted in a decrease in the forces required for axial derotation and lateral bending, coupled with an increase of the displacement of the vertebrae. This finding suggests that surgical release of the costotransverse and costovertebral ligaments can facilitate segmental correction of the scoliosis, decreasing the natural biomechanics resistance of this correction. Another paper testing the biomechanical rule of intervertebral disc and costovertebral joint instability of the thoracic spine, giving the result that the intervertebral disc regulates the stability of the thoracic spine, inflection, extension, lateral bending, and axial rotation. Here, the anterior release is combining discectomy and the excision of the hip, the head of the rib. Unilateral resection of the rib head joint affect partial discectomy. After partial discectomy, on the same side, procedure significantly coupled motion in lateral bending and axial rotation, resulting in significant decrease in the thoracic spine stability and the integrity that we need to release to correct the deformity of the scoliosis. We give some cases we did for it release, and we see the effect of the release on the correction we got. So this is an S-shaped curve, the COPS angle reaching 90. For here we did left side rib head release at the apex, thoracoplasty for some ribs here at the apical right side, and facetectomy for the facets of the rigid curve. It means that all types of posterior column release performed in this patient, and this is the result of correction. This is another case as well. We did costotransversectomy and thoracoplasty and facetectomy, and this is the result of the curve. The curve was 80 Cobb's angle. And this is another case which got mainly thoracoabdominal curve rigid. For her, we did anterior release of the disc between D12 and L1 and L1 and 2, and just breaking the rib of the 11th rib, and this is the result. We didn't correct this one, which is giving some shoulder inequality. Take-home message for this discussion is in order to achieve the target correction, we have to do or perform a good release. The types of release is affected by the degree of the curve, its flexibility, the site of maximum curve, the degree of the thoracic hump. Thank you.
Thank you so much, Dr. Hisham, for your presentation, highlighting the importance of release and correction of a spine deformity. We'll open for comments and questions between the panelists, and any one of the attendees want to ask, please write the question in the question and the answer box, and we will answer it. And afterward, we'll see just interesting case from our friends in Lahore, Pakistan. Dr. Amir Aziz and Dr. Saad Ilyas will present this case. So if there is any question for the previous speakers or comment from the panelists. May I ask Dr. Hani Sulaiman regarding his case? Dr. Hani.
Yes, Dr. Khattab.
Dr. Hani, it is a really challenging case that when you asked me what to do, I told you that I will try to manage her and help her quality of life, to improve her quality of life, as you said. But before I will do MRI, CT scan, and the traction, and assess her well, and of course the plan may be as you did, fusing her from D2 to L4. So why you got the courage to manage her directly? Did you feel that it will be flexible at the surgery? How you decide to take the courage? And is this will be your regular management technique for such severe cases and curves?
Thank you, Dr. Khattab, for your question. Just I want to share the presentation again, because it's impossible for this patient to stop at L4. It was extremely impossible.
5, okay, 5. Anyway, no problem.
Okay.
Is this the routine way?
Yes, this is a routine way, because as you know, we in Egypt, exactly the same like Pakistan. I enjoyed the presentation of Dr. Amir Aziz telling us that they have huge deformities, and you and I know very well that we also here in Egypt, we have huge deformities, huge neglected deformities, and we have to deal with them. the problem is that some of them came too late with respiratory problems that you cannot go with her to the operation room. For the patients that's still like operable, it is risky, and we explain the risk for the patient and the family, and we expect everything. In for me, it is life-saving surgery, and I tell the family that this is not a deformity correction surgery, this is a life-saving surgery, and we do lots of this severe deformity the same way.
What was forced vital capacity and forced expiratory volume?
It was in the
for
presentation
this
like
patient?
44% vital capacity.
Okay. Thank you, Dr. Hani.
Thank
So,
you.
any further comments for the previous speakers?
Dr. Muhammad.
So yes, Dr. Wael.
Yes,
تفضل.
Dr. Wael, you have a
Yes.
question?
Yeah. Okay.
Please, Dr.
Yeah,
Wael, go
I have
ahead.
a question. Okay, I have a question for all the panel, especially Dr. Yusri and Dr. Amr, if he is still with us, about the topic that
Yes.
already Dr. Salah from Mecca presented, that about, let's say, the new technology in the spine. And we know nowadays always we are hearing about the artificial intelligence in the spine. It's coming now. The very intelligent chip is coming. It will enter all the devices in the theaters, not just only the surgery. Now we know that it's still the navigation and the robotic in maybe the beginning, but I think in the next 10 years that will be an evolution in this kind of technology. So the things that we always heard from the companies that we deliver this kind of technology, that if you will catch the train right now, you will be in, otherwise you will be out. I know it's very expensive. So the question that for the panel, that do you think that Dr. Yusri or Dr. Salah, if we didn't start to use such kind of technology now in 2020, what will be happen for us as a surgeon on the 20th, let's say 2030?
Let me answer this way. We now have the OR in our premises, and we had it now for more than a year. I must be honest, it hasn't added much to our practice. It's there if we want to use it. The hassle of turning it on and the cost effectiveness of using it per case, I don't think it's the cost. So if you can afford it, why not? If not, we've been working without this modern navigation for years, and we're doing the same job. So that's my opinion.
Yusri, I'll answer it in a much simpler way. We don't need Mercedes to get from A to B. We are very happy with Toyota Corolla or Honda City or Civic. So once we can afford it, fine, but there is no need to despair. I think the companies oversell what they are making, and 10 years down the line, majority of these things take a position in the store rather than becoming a regular part of our armamentarium. We should develop, get things that we can afford, but be very pragmatic as to what their usefulness will be.
I totally agree, Amr. This is a nice explanation. And from the past, I've been doing spine surgery since 1983. And I would say what added to our experience and to our results are two things. The neuromonitoring. I remember the first neuromonitoring in the 80s, it was crude neuromonitoring, but now it can tell you which muscle has been affected and when, and how is the recovery. So this is the one thing, is the evolution of the neuromonitoring, and the other, the evolution of the surgical techniques and the instrumentation. So I would think, apart from these two, the technology hasn't added much to our practice.
Absolutely. Spot on.
Actually, I was going to mention what Dr. Yusri said. If I have to choose between one of the two instruments you use, either monitoring or neural navigation, I will choose the monitoring because actually it is more important and it will affect the quality of the surgery. Most of us using the freehand technique. So for sure, if I have an extra advantage of technology, it would be better. But as the Dr. Yosri mentioned, for sure, the monitoring is much more beneficial because most of us, because of the situation, monitoring is not available in all our hospitals here in Egypt. So in severe tough cases, we use monitoring, but most of the cases we're using the waking up test up till now. So totally agree with Professor Yosri.
And the joint surgeons are now using a robot to cut the femur or the neck of the femur or to do the knee replacement. And this can differ with 1 or 2 degrees, but the end, I think both any patient with robotic knee put in or non-robotic knee, they will walk the same.
So great. If there is no more comments, so I'd like Dr. Saad to present his interesting case.
This is specially for Hani.
Thank you.
Okay, thank you, Dr. Amr.
This is a 32 kilogram lady, aged 18, 19, neurologically intact, presented to us with this tumor subcutaneously. Can we move this forward, please? Next slide, please. This is the back. This is the girl, hardly able to walk. And this is the curve, Hani. This is the curve of the spine. So her total weight was 32 kilograms pre-operatively. And this tumor was resected today by our plastic surgeon. And this tumor weighed 8 kilograms. So the child was then left with total weight of 24 kilograms. And for this deformity of the spine, we put our device today. Saad did the honors. This is her. She was transfused 5 liters of blood, and our anesthesia team has chosen to voluntarily ventilate her overnight. And inshallah, tomorrow she will be extubated and we will start to walk her, gradually distract her. And once she straightens out, we will then stabilize the spine. Thank you.
Excellent.
So, Hani, over to you.
Excellent. I wish you will show us her post final follow-up.
I will, inshallah. I'll send it to you.
Thank you, Dr. Amir, and thanks for all our faculty, Professor Ron Al-Hawari, Professor Walid Awad, Professor Amir Aziz, Professor Salah Din Khalifa, Professor Samir Sami, Professor Wael Al-Qasim, Professor Baron Lunar, Hani Sulaiman, and finally, Dr. Hisham Shakir. Thank you so much for supporting the Egyptian Scoliosis Society, and see you, inshallah, in the next year. I hope physically, inshallah. And 5 minutes only to stretch our legs. Then we will start the surgical tips and the tricks. And today we will discuss only screws in spine deformity. So 5 minutes, and then we will start the next webinar, surgical tips and tricks and screw application in deformity surgery. Thank you so much. Thank you for all.
Thank you. Good luck. It's midnight here. We are off to sleep now.
Thank
Good
you,
night.
Dr. Amir. Good night.
Assalamu alaikum.
Have dreams.
السلام عليكم جميعا.
عليكم السلام ورحمة الله وبركاته.
متشكرين
دكتور
جدا
هاني،
دكتور
شكرا
محمد،
جزيلا.
متشكرين
Good
دكتور
luck
يسري،
ahead.
شكرا جزيلا، اشكركم.
Good luck. Excellent presentation. Good luck.
سلام عليكم. الله يكرمك، الف سلامه.
عليكم السلام ورحمة الله وبركاته.
كده ماشي. مطلوب منه اللي هو طبق كده وفوقيه طيب ما اجي بقى اقعد بكتب بالشير سكرين واظهار الحاجه اقوم فاتحها من على الديسكتوب.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody. Thank you so much for joining our webinar. It will be screw application in deformed surgery, and I am happy to moderate the session. And we have great panelists, Professor Yusra Al-Hawari, Dr. Muhammad Sirri, Professor of Orthopedics and Spine Surgery in Mansoura University, Dr. Sharif Al-Ghamri, and Professor Dr. Hisham Shakir from the Military Academy. Dr. Sharif.
Yeah, Dr. Muhammad.
Are you ready with
Yes.
with your video? So we can start by this video.
Yes.
Please.
Hi everyone. This is our second day for the surgery. Remember yesterday we have put our first screw and identified our first screw by image. Now we continue putting all the screws. So we put the screws in the concave first, and then we may put the screws in the convex. We use the same method, put some screws on the concave side. Now we can check it here. And we reach the upper thoracic level. Remember now the head of the patient is up and the main surgeon on the left side. Now he's trying to put the upper level screw. So either you put the screw or you can put a hook if we fail to put a screw. So we have the options. Now we are putting the screws on the thoracic curve. And as you can see here in the concave side, and the convex side, still we didn't touch it, even we didn't strip the muscles from it. So the option is to put polyaxial screws or monoaxial screws. And we will discuss this today. وإيه اللي حصل؟ Now we continue putting the upper level screws. Again, you can see the field is almost bloodless. Facet using the chisel. As I said yesterday, we use every facetectomy for all the levels. And then move out of the pedicle to expose pedicle, and then use the awl again, the pedicle finder to put the screw. After we finish this step, we cover the wound and we check all the levels we have screws in by image intensifier in both AP view and lateral. If we are satisfied, we can continue this. In the apex, we put the fixed screws, and in the other side, in the other levels, we have polyaxial screws. Again here, we use the chisel, the facetectomy, lift out of the facet, and then put probably the last screw here. Check the walls. If we are satisfied, the polyaxial screw. Of course, if we cannot put a screw, we can have the option to put a hook. Here you can see the direction of the pedicle finder is changing till we reach the desired position and insert the screw afterwards. Now we cover the wound to check the X-ray. Thank you for today.
Thank you so much, Dr. Sharif, for this nice illustrative video. May I ask you, Dr. Sharif, at the night of the surgery or the day before the surgery, how you actually prepare the instruments and the implants? What is the information that you give to the company, and how to decide that you will use screws, you will use sublaminar wires, hooks? Can you give us some clues regarding this point, Dr. Sharif?
Yes, thank you. It's a very important step and a part of the operation, of course, that you discuss what you are going to, the plan of the surgery and what levels are you going to fix. And Dr. Yahya yesterday explained the surgery map that we are using. So on the day of the surgery, we already know now what levels are we going to fix and to put the screws in. And we all in the, so I asked the company, of course, to bring everything. And with 20 screw of each size, polyaxial, monoaxial, and even sublaminar wires for just in cases we need them. And it usually works if you're going to, if you know your plan. And on the day of the operation, we discuss it again, and we tell everybody that we are going to fix, say, from T4 to L1, for example. So everybody in the room, including the company representative, know what we are going to do.
Okay. Professor Yasri, we saw in the video that there is a pointing Homan. Why you use Homan instead of self-retaining, and what is the exact location of this Homan?
The Homan retractor is the cheapest retractor and the most efficient retractor you can get, because the muscle damage is much less than putting other retractors. You can always change the position, but when you put a retractor and leave it there, it does much damage to the muscles. So if you just place your tip of the Homan retractor at the tip of the transverse process or under the junction between the transverse process and the rib, you get a good retraction. And even you can make your incision less by using the Homan retractor.
Great. Professor Hawari, do you use neuromonitoring regularly in your cases? And do you rely on stimulating the screws while doing neuromonitoring?
You shouldn't do what I do, because from the experience of like 35 years of scoliosis, so I won't use it regularly except for severe curves or when I'm doing an osteotomy. But this is not the standard treatment for any beginners or mid-term spinal surgeon. Use it in all cases.
Okay,
and for
great.
stimulation of the screw, yes, if you have this option of it helps, especially in the lumbar screws more than the thoracic.
Professor Yusri, is the flexibility of the curve affect your implant choice?
Sometimes you see an X-ray with a severe curve, but just do a traction film and you find that the curves gets much correction, especially in hyperlexia syndromes and Ehlers-Danlos. So don't be fooled by a severe curve in an X-ray. Most of these curves in AIS they are flexible curves. So I would rely on traction films, or just by examination and feeling the hyperlaxity of the ligament, then you'll be pleased to have such patients, but because you know that you will get a good correction.
Okay, but is it will it change the screws, sublaminar wires, the implant choice affected by the flexibility of the curve?
Usually our range of screw density ranges from 100% to 70%. This is the usual range. So I would say in protic bone, in double curves, you need more screws. In rigid curves, you need more screws. In flexible curves, you need less screws. So I would go for 70% in flexible curves and 100% in rigid curves.
Okay, Dr. Mohammed Sirri, regarding there are different types of screws, monoaxial screws, monoplanar screws, polyaxial screws, long crown, short crown, different types of armamentarium that we have, like hooks, sublaminar hooks, transverse process hooks, facet hooks. Recently, there is a tapes replacing the sublaminar wires. Do you have some tips and tricks regarding using these different kinds of metal, and during application of the screws, do you have some tips and tricks where to and how to apply the screws in the upper dorsal spine, mid dorsal, and the lumbar spine?
Yes, I usually use all pedicle screws, mostly polyaxial screws. Polyaxial screws. Monoaxial screws can increase the rate of correction of the rotation at the apical area, but may be difficult, especially in severe curves, to connect the rod to the monoaxial screw. So most of cases I use all pedicle screws. As regards the steps, you want to know the tips in application of the pedicle screw insertion?
Yes, yes. You showed us in your presentation 2 days ago the gear shift, how to use the gear shift in the concave side and the convex side.
Yes, the entry in the thoracic screw is should not be lower than the mid transverse line, transverse boss line, and should not be medial to the vertical line of the passing through the mid facet joint. In upper thoracic and lower thoracic, it is slightly lateral to this vertical mid facetal line. In the mid-thoracic area, it is slightly medial. Also, in the concave area, it is slightly lateral. The direction of screw on the concavity is medially, and on the convexity is lateral. Start by after locating the entry, you direct the gear shift laterally until you pass the spinal canal for about 20 millimeter, then to avoid cord injury. Then directed medially to medial incline to avoid vascular injury, laterally placed screw, avoiding the vascular injury. This is the direction of the gear shift. Yes.
Okay, thank you, Dr. Mohammed. Professor Hisham Shakir, do you use in-out-in technique in some cases?
Yes, Dr. Mohammed. Some cases when the pedicle is too narrow, we can use the in-out-in screw to hold the vertebrae. But this is when we cannot put the intrapedicular screw. So we try first to put the intrapedicular screw in the pedicle, but when it's difficult, so we can shift to the in-out-in.
Okay. Do you recommend it, Dr. Hisham, in cases of neurofibromatosis and dural ectasia and these dysplastic pedicles? You can recommend this technique in such
Yes,
cases?
sure. Yes, sure.
Do you use the navigation, Dr. Hisham, while application of screws in deformity cases or in revision cases?
Yes, we got the chance for some time of our work that we got the O-arm, and we use it in cases with less elasticity curves and severe derotation of the vertebrae. We use the navigation, and it give us a very good screw positioning. But it requires a lot of work to get this. I mean, the O-arm, you have to fix the patient, and you take the shots and reconstruct the images in the computer, and then we work. But we don't have to move the patient during this work to get the normal navigation or the accurate navigation.
Okay, Dr. Sharif, what is the commonest screws sizes that you use? Also, I'd like to ask you regarding, are you routinely tab before screwing the pedicle?
Every single screw. Every single screw use the tab. And you have to check. Usually it is 545, 645 are usually the most common sizes we use.
This is the commonest diameter, 6.5 in the lumbar spine, 5.5 in the dorsal spine.
645, 640.
And for the length? 45 and 40.
45, 40. And the upper screws, we usually use the 35 usually.
Okay. Professor
Mohammed,
Hawari, yes.
Can I add, we do under tapping. We never tap the size of the screw we're going to put. We'll use the 4 millimeter usually. The beauty of the tap that you can feel with your measure the threads of the tap, so you know that you are in the pedicle.
Okay, great. Professor Hawari, regarding cases with osteogenesis imperfecta, osteomalacia, renal osteodystrophy, and severe osteoporosis, what is the instrumentation that you can manage these cases?
You have to remember, in such cases, the lamina becomes the strongest part of the vertebrae rather than the pedicle screws. So don't forget that you have lamina. You can do a sublaminar tape or wires together with the screws, and you can put hooks. You can do a clamp. So there are other modalities, and even you can skip the pedicle and put your screw directly into the body and away from the nerve, so you can get a purchase in the body.
Okay. There is a question from one of the attendees asking about using straight or curved gear shift. Dr. Hisham, which kind of gear shift that you use, curved or straight? Which one you prefer?
Sorry, what? I don't.
Gear shift, the pedicle finder. There are two types, straight one and the curved one.
Malleable one.
Which one you prefer?
Malleable one.
Curved, you mean? Curved?
Yes, curved and malleable.
Okay.
Yes,
Dr. Yasri?
Curved one. What's called the Lenicky pedicle finder?
Okay.
Exactly, the curved one.
Okay. Regarding the strategy to apply the screws, what is the minimum amount of the screws, and where is the best places to apply the screws? Dr. Serri, can you answer this question?
Yes. The minimum amount of screws or screw density should be not less than 60% of the available pedicles. to achieve stable proximal and distal fixation with good apical control. The screws around the concave apical area is the most important for correcting rotation of the apical vertebrae and the thoracic hypokyphosis. With this, and lower and high density screws give the same results as regards the correction and the fusion rate, with lower implant cost, operative time, blood loss, and complications. But should not be less than 60%. That's to mean one level, one screw per level.
Okay.
So you should fixation of the apical area to do the rotation and with stable fixation proximally and distally.
Yes, Dr. Seri, and you told me that you use usually all screw technique and you use polyaxial screws in most of the vertebral.
Yes.
Dr. Yusri, do you use mainly polyaxial screws as well, or you have another strategy?
If you can put solid screws, that's the best, because you can derotate. Because if you use derotation with the polyaxial, the tulip will move, not the screw itself. But sometimes if you do this, it's difficult to put the rod. But I would use, if I'm using at the apex a solid screws, I would use extended screws. So I can put the rod through these extended tulips, or I can use the smart links or whatever system you're using. So I would go for solid screws rather than polyaxial. If you have a uniplanar screw, that will work in between the solid and the polyaxial. But in severe curves, I would use the polyaxial.
Dr. Hisham, what is your strategy while applying the screws?
Yes, Dr. Mohammed. Our strategy, the last one we are working with, is to put every vertebra in the concave side screws and less amount in the convex side. And we use the uniplanar screws mostly. In the transitional area, we put fixed screws at the end of the curve. And at the upper and lower anchor, we put polyaxial screws. The ideal is to put whole screws to get the better correction. But economically, we try to reduce the amount of the patient can pay or cost him. So we do the concave side, all screws of the curve, whatever the lumbar or the thoracic, and less amount, I mean every other vertebrae in the convex side.
Okay, Dr. Sharif, do you have any comments or any question for the panelists, or something that you want to highlight, or any one of the panelists want to highlight something in the
I have a question to all of us who believe in the bicortical screws. Bicortical screws. You put a screw, you have to make it a bicortical.
You can use this in osteoporotic bone. You have only 0.5 centimeter to be out of the vertebrae without causing any damage to the vessels. So, in some papers, they say it's 1 centimeter because you have soft tissue between the bone and the vessel. So be careful that you can't be more than 1 centimeter, better 0.5 centimeter. And you can use it in osteoporotic cases. And also in osteoporotic cases, you can angle your screws to go in the tricortical bone and either the superior part or the inferior part of the vertebra.
Do you tap, Professor Yusri, do you tap osteoporotic cases?
As I said earlier, I tap because I want to feel the threads to make sure that you are in the vertebrae. And I always under tap. I always, most cases, I will use the 4 millimeter tap.
Dr. Seri, would you like to comment or say something?
Tapping is very important, especially when you do multiple trials of cannulation of the pedicle.
أنا قاعد في الأرض في الريسبشن يعني.
Okay.
بس ثواني.
My final question actually to the panelists is what to do if you have pull out of the screws during the correction.
First, you have to avoid that by dividing your pull or your tension to be on several screws instead of having on one screws. And if you find that the screws is pulling out, try to bend the rod more so that the rod will go to the screw instead of the screw going to the rod, and go to the level above or level below so that you can decrease the tension on the pulled out screw. But I won't remove it because at the end you are putting several screws, and I would leave it as such. There is no hassle to take the rod out and then remove the screw. You don't need that.
Okay. So,
are you in favor of using the cross connector?
Say again, Sharif.
Are you in favor of using the cross connector, especially if there's a pulled one, there's a pulled screw?
There is no cross connector. It's to be used because the body is your cross connector, and most of the cases of infection or delayed infection, the infection starts at the cross link. So I think this is, to me, is something from the past. I don't use it. Your cross connector is the body.
Dear panelists, all of you are using freehand technique for screwing deformity cases? Freehand technique, all of you?
Yes.
And,
yes.
And only one or two or maximally 4 fluoroscopic shots after finishing the screwing, right?
Yes.
Yes.
Okay, great. So we don't have any more questions, and so I'd like to conclude the session by this phrase of that screws are strategically positioned to allow optimum deformity correction, and we aim to of course decrease the neurological risk following these tips and tricks. Of course, less surgical time is beneficial for our patient to decrease the surgical trauma and decrease the blood loss. And of course, if you can use low density screws, that will decrease the instrumentation cost, and it will help your economic in your country. So I'd like to thank Professor Yusuf Hawari, Professor Hisham Shaker, Professor Muhammad Sirri, and my dear friend, Dr. Sharif Al-Ghamri, for being between us. And I'd like to thank all the attendees and see you tomorrow, inshallah, in the 4th day. Thank you so much. Assalamu alaikum.
Thank you, Muhammad, and thank you for all the speakers and the panel.
Thank you for all of us.
Have a good night. ازيك يا هشام؟ وحشنا حبيبي.
ازيك يا فندم؟ ربنا يخليك، انت اكتر. ازيك يا فندم؟ يا حضرتك. اشوفكم على خير كده ان شاء الله.
ان شاء الله دايما ان شاء الله.
شكرا جزيلا. السلام عليكم. السلام عليكم.
هشام، ازي حضرتك؟
ازيك يا فندم؟ حضرتك ايه؟
اهلا، ازي حضرتك؟
اشوفكم على خير يا فندم.
ازيك؟